so glad to be a part of the Scientix conferences and to present between my pioneer colleagues on research in different fields. I'm really happy and glad to attend the presentation, and hopefully each year I will be part of the conference to participate with my studies. Today, I will present my latest study. It's about predictors of social support among Saudi Arabian postpartum women. This paper was prepared by me as the first author and my co-author, Dr. Imad Shidefat and Dr. Fatima Annas. I am assistant professor at the College of Nursing, Imam Abdulrahman bin Faisal University. Just here, a quick literature review about social support among postpartum women. Postpartum depression has been recognized as the most frequent complication of the childbirth. It is characterized by strong sad feelings, high levels of anxiety, and tiredness after giving birth that last for a long period. These feelings can make it challenging for women to care for herself and her new baby. In a recent study in Saudi Arabia, 59.7% of the postpartum women have been identified to have postpartum depression. Another study found that significant predictors of the postpartum depression among Saudi Arabian women were family conflict, lack of partners, and family support during pregnancy. Social supports helps postpartum women recover from childbirth and promotes healthy motherhood infant development. Therefore, the objective of our study was to explore the predictors of the perceived social support among postpartum women, and specifically we chose the eastern region of Saudi Arabia to study those predictors at a university hospital that is attached with the Imam Abdulrahman bin Faisal University. Regarding the methods, our study design were a quantitative cross-sectional study design. Participants were 86 postpartum women. We chose those women within a 6 weeks after delivery, and they were range age from 18 to 49 years old as inclusion criteria. Our study tool it was the multidimensional scale of the perceived social support, MSPSS. It contains 12 items that must be rated on a 7-point Likert scale. The responses for each item range from 1, very strongly disagree, to 7, very strongly agree. It evaluates family, friends, and important person for the social support. We use the Arabic translated version of this scale, and it shows high level of the validity and reliability. We use another socio-demographic and obstetric history form, which was made by the study researchers. It's asked about age, employment, educational level, employment status, and about the number of the pregnancies, number of the abortion, number of girls and boys, and so on. Before we start our study, we talk the ethical approval from the Imam Abdulrahman bin Faisal University Institutional Review Board, and we follow Helsinki Declaration for the privacy and confidentiality of the patient, and we secure consent form before we start data collection. We contacted those participants through the outpatient nurses. Then we give them a barcode that's include a link for the study questionnaires, and we give them invitation letter, and they have the full right to participate in this study and to withdraw at any stage of the study. Regarding the data analysis, research data was managed and analyzed by the SPSS software. Social support, which is measured by the MSPSS, was calculated based on its manual for the calculation. Descriptive analysis was done by calculating the percentage mean standard deviation. For the inferential analysis, we use t-test and ANOVA. Moreover, multiple regression analysis was used to find the predictors of the social support. Results were considered significant at the level of the P0.05. Regarding our results, here just the general demographics and obstetric statistic for the study participant. Most of the participants were married, 59.3%, and had a higher education degree, 40.7%. Over half of the women, 55.8%, were jobless. They have unemployment status. Moreover, the study revealed that 41.9% of women had 1 to 2 children only, while the rest they will have more than 3 or more than 6 kids. Regarding feeding, most of the women preferred breastfeeding. In terms of the mode of delivery, 67.4% of they have CS, and they have large number of the cesarean section. Finally, 43% of women experience diseases during pregnancy, and 27.9% were diagnosed with a history of the depression. Here in this result, in this slide, table 1, it shows the distribution of the MSPSS score among participants. For the moderate level, 30 of the participants, it's account for the 34.9%. They reported to have moderate perceived social support, while 65.1 they perceive they have high level of the social support. So these findings suggest that majority of the participants in the study perceive high levels of social support, which could have a positive impact on their mental health and overall well-being. Here in this table, it will show us the multiple regression analysis of the predictors of the social support. Based on the significance level, we can find that women who has kids, more than 4 kids, they will negatively, the number of more than 4 kids, they will have negative impact in their social support. Women who live in extended family, they will have positive social support, and women who will not follow the traditional practice that some culture follow within 40 days or 20 or 2 weeks after delivery, the women who will not follow those traditional practice, they will show negative correlation with the social support. Here, the study finding revealed that social support scores are influenced by some factors. Those are the predictors, specifically having no children or having more than 3 children, that is in the category of the 4 to 6 kids, negatively correlate with the social support score. The type of family structure has a significant impact. The extended families associated with higher social support. The absence of a traditional practice is also significant predictor with a negative correlation to social support. Regarding the interpretation of our study result, here in this discussion part, the perceived support reported by the participant in this study, the high level of the perceived social support, it was aligned with the previous studies that was indicate perceived high level of the social support, and it has a positive impact on the mental health of the woman during this critical period of their life. Another things regarding our result, that women who have large number of children, we can rationalize this result. A high number of children, it will correlate with poor or low social support. This can be rationalized by that large number of children place mother at a higher risk of experiencing fatigue and neglect their self-care, thereby significantly increase the likelihood of postpartum depression, as the woman need to take care of her new baby and the other 4 or 5 or 6 kids as well. Regarding our result in regard to the extended family, women who are surrounded by extended family tend to receive greater support. This can be attributed to the participation of the various individuals with their respective experience, allowing for the increased care provision for the woman, especially when the women live in their extended family with their grandmother, grandfather, auntie. They will help the new mother to cope more and help her with her new responsibility as a new mother for the new born. And for the last result, the association between traditional practices and high stress levels or maybe poor social support may be explained by the tendency of the individual to seek alternative solutions when they feel desperate, particularly during the postpartum period and particularly when dealing with depression. As we know, some of the traditional practice, it will not really help women to revive after her childbirth, and this may be placed women in more stress just to revive and just go for her normal life and routine. Our recommendation for our study, this study revealed important connection between demographic factors and stress among postpartum women. We also observe a high level of perceived social support in our sample. Customized intervention are essential to promote the well-being of postpartum women, and further research in this field is needed to deepen our understanding. And it is very important to highlight that our study, we have some limitation. The limitation are in the form that this is a study, it is a cross-sectional study, so it will not allow for the generalization of the study as we measure the social support as a certain point of time, and only we choose one place for data collection. So we cannot generalize our study for other clinics or other hospitals in the Saudi Arabia. Also, we use a self-reported questionnaires that maybe cause data bias, as women maybe they will have a problem with just remember or recall of the information within only 7 past days, within a week. And this is the end of my presentation. I will be happy and welcome you if you have any questions to ask me. Ask me, please.
All right. Thank you, Dr. Amira.
Understanding necrotizing enterocolitis. Necrotizing enterocolitis is one of the most severe acquired gastrointestinal disease affecting neonates. Due to the lack of reliable biomarkers, timely detection of severe forms and differential diagnosis of NEC remains challenging. Differentiating NEC from other conditions with similar symptoms is crucial for determining an effective treatment strategy. Study design overview. Our prospective case control study was conducted in the intensive care and full-term neonatal pathology unit of the Scientific Research Institute of Pediatrics, named after Farajeva in Baku. The aim was to assess the diagnostic capability of the biomarker nitric oxide in differentiating NEC from sepsis in full-term newborns. The study includes infants with a gestational age of 37 to 42 weeks, weighing between 2,500 and 4,400 grams. Demographic and clinical data were collected from patients exhibiting abdominal and systematic symptoms associated with NEC. We examined 100 full-term sick newborns diagnosed with NEC, and all levels were measured in the blood of both groups. Data analysis and key findings. Raw carb analysis was employed to evaluate the diagnostic capability of this biomarker. Elevated levels of NO were observed in 83 patients, while 17 patients with septic complication showed opposite test results. NO levels in patients with septic complication were significantly lower than those in patients diagnosed with NEC. These findings suggest that changes in NO levels can aid in detecting severe forms and septic complication of the disease. Because the clinical presentation of NEC2, NEC3, and NEC sepsis share similarities, these patients groups were compared using ROC analysis, taking into account various combinations of biomarkers in patients with NEC sepsis. The highest diagnostic value was observed when using NO, indicating that it is sufficient in differentiate NEC from NEC with septic complication. The results underscore the significant role of NO in the pathogenesis of NEC, positioning it as a promising marker for developing new diagnostic and management approaches for these conditions in full-term newborns. The observed change highlights the clinical importance of NO measurement in children with NEC, particularly concerning the disease progression. Specifically, increased NO production in NEC and decreased levels in NEC sepsis confirm its role as a pathological indicator. We found that NO has a highest specificity among the studied markers for detecting sepsis. If the NO level is less than 37.8 millimoles liters, it raises concerns about potential septic complications during the clinical course of NEC. This critical threshold can facilitate the timely detection of sepsis, optimizing treatment strategies and patients in management. Drug treatment for severe forms of NEC is often insufficient for achieving favorable outcomes. Timely detection of disease progression and accurate differential diagnosis of NEC from similar conditions are essential for optimizing treatment and preventing complications in newborns. Our study demonstrates that NO can serve as an isolated biomarker for differentiating severe forms of NEC from septic processes throughout treatment in full-term newborns. Hyperproduction of NO in NEC hyperproduction of NO in NEC linked to hypoxic central nervous system damage and mesenterical hypoperfusion accelerates intestinal epithelial damage and impedes recovery, leading to bacterial invasion and inflammatory activation. Conversely, hypoproduction of NO due to NOs with the progression in infection also contributes to intestinal damage in newborns. Therefore, the increased production of NO levels can be utilized in the differential diagnosis of NEC from septic complication and in developing a testing algorithm for full-term newborns. Our mathematical model can help identify the onset of sepsis in NEC patients. Measuring serum NO levels is sufficient for this purpose with an accuracy of 87%. Timely determination of critical NO values will enhance the understanding of underlying pathological process and improve the differential diagnosis of NEC versus sepsis, thereby optimizing early diagnosis and management. Thank you for your attention.
Endometriosis through gut and reproductive tract. Now, as we all know, that endometriosis is an estrogen-dependent chronic inflammatory disease that often leads to pain and infertility. The prevalence of endometriosis in women of childbearing age is 10 to 15%. For the women with abdominal pain and unexplained infertility, the incidence is as high as 40 to 60%. To the data, there are many theories about the pathogenesis of endometriosis, including menstruation and countercurrent. However, none of them fully elucidate the specific mechanism, which has become the major reason limiting the breakthrough progress in the specific mechanisms of endometriosis. Endometriosis treatment in recent years, with the development of genomics research and high throughout sequencing technology, a large number of studies have shown that the human microbiome has a significant relationship with the female reproductive health. So today we have taken this study that it will show that the gut microbiota is associated with many inflammatory diseases, that there is an association between the gut microbiota and endometriosis. The mechanism by which the gut microbiota affects endometriosis, it may involve estrogen, immunity, inflammation, and tumor characteristics. Thus, targeting the gut microbiota may help in the treatment of endometriosis. So in this figure, we can see the estrogen gut microbiome axis, which is present in endometriosis. As you can see, that this dysbiosis of gut microbiota can produce beta-glucuronidase, which increases the level of circulating estrogen through the enterohepatic circulation, and thus it causes the endometriosis. Coming on to the role of gut microbiota in the pathogenesis of endometriosis. Endometriosis is an estrogen-dependent disease that is characterized by the presence of endometrial glands and stromal cells outside the uterus. The estrogen plays an important role in maintaining female reproductive system and development. Estrogen can regulate the microenvironment of the female lower genital tract by increasing the epithelial thickness, glycogen levels, and mucus secretion. And it is indirectly reducing the vaginal pH by increasing the lactobacillus abundance and lactic acid levels. In this picture, we can see the role of gut microbiota in the pathogenesis of endometriosis. This figure depicts the role of gut and reproductive tract microbiome in the endometriosis development. This is an overview of the relationship between the gut and the reproductive tract microbiome and endometriosis, which focuses on the mechanisms by which the dysbiosis may increase the risk of the disease. Endometriosis is caused by an endometrial cell engraftment outside the uterus, and this is characterized by the inflammation throughout the periodic hemorrhage from the ectopic endometriotic lesions. The dysbiosis favors inflammation via the specific inflammatory immune response, cell recruitment, pro-inflammatory cytokine production, and compromised immunosurveillance. The gut microbiota can accelerate inflammation and affects the pathogenesis and progression of endometriosis by a dysregulation of the estrobolome and metabolome and the gut-brain axis. There was a study which was done by Merhem et al., which have found that estrogen can reduce proliferative diseases such as endometriosis, endometrial cancer, and hysteromyoma by stimulating the proliferation of female genital epithelial cells. The microbial genome shows that the multiple bacterial genera in the gut microbiota can produce beta-glucuronidase. This includes bacteroid, bifidobacterium, E. coli, and lactobacillus. Notably, in the feces of endometriosis patients, the E. coli content was significantly high. The gut microbiota can lead to an increase in circulating estrogen levels, which is helpful in creating a high estrogen environment for endometriosis progression. Now, there is a big question. Does endometrial dysbiosis can cause early pregnancy loss also? So, by looking at this picture, we can see that this is a composition of diversity where there is low biomass environment and compositional overlap within the vagina. There is dysbiosis within the microbiota, and hence it is associated with increased diversity. Now, coming on to vaginal microbiota, the lactobacillus depletes vaginal microbiota and is associated with pregnancy loss, but causality is not established as yet. The high risk of cross-contaminating endometrial samples have been found. There was an association also found with the pregnancy loss. These were the observational study who reported the altered composition and diversity in pregnancy losses, which are compared to the controls. There was a potential mechanism in which there was found that the microbial interaction may dysregulate the inflammatory pathways and affecting the trophoblastic invasion, the spiral artery remodeling, and endometrial senescence, which altered endometrial receptivity, function, and predisposition to pregnancy loss. So there was a brittle association which was found between the endometrial microbiota and the early pregnancy loss, in which the females experienced recurrent pregnancy losses in these pregnancies. The human endometrium, as we all know, is a dynamic entity that plays a pivotal role in mediating the complex interplay between the mother and the developing embryo. Endometrial disruption can lead to pregnancy loss, impacting both maternal, physical, and psychological health. There is a suboptimal or dysbiotic vaginal microbiota, which was characterized by increased microbial diversity and reduced lactobacillus dominance, and this has been associated by various adverse reproductive events, including miscarriage. Recent observational studies implicate that there is a potential microbial continuum between the vaginal and the endometrial niche in the patients with pregnancy loss, which is a dysbiotic endometrial microbiota, which may modulate key inflammatory pathways which are required for successful embryo implantation and further pregnancy development. In this figure, we can see the biological plausibility of the endometrial microbiota and the miscarriage. In an optimal state, in this picture, we can see there is a low levels of commensal bacteria which promote host immune and inflammatory response supportive of the endometrial function. And here the epithelial cells will produce antimicrobial peptides, chemokines and cytokines, which are helping to maintain the epithelial integrity and repel potential pathogenic bacteria. These commensal bacteria and their metabolites will interact with the antigen-presenting cells to modulate immune tolerance, including the formation of specific T cells. In this figure, we can see that there is a formation of specific T cells, such as regulatory T cells, and there is a formation of Th1 to Th2 cells. These Th2 cells will secrete interleukins, interleukin 4, 6, 10, and 13, which are important for the cytokine hemostasis and the pathogen resistance, where the uterine natural killer cells interact with the trophoblast HLA to modulate immune tolerance and secrete the interferons and vascular endothelial growth factors, which are responsible and involved in the spiral artery remodeling for the normal placentation. Now, coming on to the shift towards the dysbiotic endometrial microbiota and increased pathogen colonization, this could reduce the cyclic AMP. These AMPs and chemokines and cytokine production, which is resulting in the loss of epithelial integrity and increased, as we can see here, there is an increased permeability in the formation of these cells. And there is a loss of epithelial integrity and bacterial translocation. These abnormally activated APCs will drive the aberrant immune pathway activation, and they include the changes to the T cell production, leading into the increased ratio of Th17 and the transformation of Th2 to Th1 cells, ultimately leading to increased tumor necrosis factor A production, and which has been implicated in the abnormal pregnancy development. Altered stimulation of uterine natural killer cells. These may affect angiogenesis and multifetal immune tolerance and plasma cells in the endometrial stroma, which may reflect an immune response to pathogens, and this may impair the endometrial receptivity. So now, targeting the gut microbiota for the treatment of endometriosis. As it is a chronic disease with the recurrence rate of 10 to 15% in a year, so these women will experience severe pain with menstruation during sexual intercourse and can not only cause severe health problems, but they also interfere with the normal activities during the work. So the gut microbiota imbalance has many adverse effects on the body, and correcting the gut microbiota imbalance to restore its normal functional state, which will provide another option for the treatment of many diseases, including endometriosis. The regulation of gut microbiota by the means of antibiotics, fecal bacteria transplantation, probiotics, and nutrients. The presence of pathogenic bacteria such as Atopobium, Bifidobacterium, Chrysidiobacterium, Gardnerella, Haemophilus, Klebsiella, Neisseria, Staphylococcus, and Streptococcus in the endometrium, together with the depletion of Lactobacillus species, is associated with impaired reproductive function. Endometriosis, hence, thus to be considered as a possible emerging cause for the implantation failure and the pregnancy loss. The abnormal gut and cervical microbiomes may be associated with endometriosis severity, including pain and infertility, possibly through the impact of estrobolome and metabolome. This microbiota, dysbiosis, and endometriosis development and progression are thought to be supported by a bidirectional relationship. The microbiota has been reported to be a major regulator of such physiological processes, not only within the gut and the reproductive tract, but also at distant sites, such as microbiota brain prostop. Collectively, microbiome composition and abundance alterations may cause endometriosis and its association symptoms, including infertility and pelvic pain, possibly through the gut-brain axis. So, to conclude my talk, considering the different phenotypes of endometriosis and the diverse clinical manifestations, the future requires a study the different characteristics of microbiota in different endometriosis patients and the role of their metabolites in the pathogenesis of endometriosis. We should find a relationship between the gut microbiota and the endometriosis by analyzing the characteristics and the metabolites of the gut microbiota in patients with endometriosis and provide new ideas for the prevention, diagnosis, and treatment of endometriosis. The correlation between the gut microbiota and endometriosis from the aspects of systemic immunity, metabolism, and tumors, amongst the other perspectives. At the same time, the gut microbiota can be treated by the means of antibiotics, fecal microbial transfers, probiotics, nutrients, and other means to intervene the endometriosis, providing newer ideas for the clinical treatment of endometriosis. These are the references. Thank you.
Thank you, Dr. Medhavi Sharma, for the excellent presentation. And
healthcare workers who have been contributing greatly to women care and child care. And basically, my topic is regarding obstetrics, specifically looking towards the reduction of blood loss during cesarean section. And as is evident in many of the studies and textbooks, the main hurdle that we face while we tackle with delivery as well as cesarean section is how to reduce the blood loss and how to reduce the morbidity and mortality associated with that. And there have been umpteen number of studies looking into different modes of approach. And this is a particular study where we are compared two different drugs. One was a misoprostol and the other was tranexamic acid. And this was a randomized controlled trial that was done in our hospital. So basically, as we know, the number of cesarean sections have been increasing since the past, and this itself has contributed to the increasing numbers of postpartum hemorrhage. Because as we know, compared to the normal vaginal delivery, cesarean section itself poses a threat for an increased blood loss, and that is why we even characterize the blood loss to be more than 1,000 ml before we call it as postpartum hemorrhage in cesarean section, compared to vaginal delivery, where even a loss of more than 500 ml is considered as PPH. So there have been lots of contributions from the literature all around the world. And what we do presently is we follow the active management of third stage of labor. That is followed even for cesarean section, where we use oxytocin infusion immediately after the delivery of the baby. And what has been looked into is, can we use other drugs also in the form of a prophylaxis rather than going for a therapeutic approach, because prevention is always better than cure. So the drugs that have been tried were misoprostol, which is a prostaglandin E1, and the usage of misoprostol sublingually, because that gives the maximum, that is the shortest duration of action towards peak action, as well as comparison of that drug with tranexamic acid in the form of an injection. And there have been studies that have compared each of these drugs with the routine care, that is oxytocin, and also with placebos. But then there have been a dearth of studies where the efficacies of these drugs have been compared head-on. And that is why we propose to go ahead with this study. We actually had a pilot study prior to this study in our same institution, where we tried to compare tranexamic acid alone with respect to the oxytocin, which was a standard treatment. And we found that tranexamic acid had significantly reduced the blood loss to more than about 150 ml. So that is why we did not have a third arm of comparing this with the standard arm, because we already had a pilot study in this form. So we tried to compare these two drugs, which was misoprostol and tranexamic acid, in our study. So this was basically to compare the efficacies of prophylactic misoprostol sublingually versus the tranexamic acid intravenously in reducing the blood loss. And we tried to assess these effects by measuring the intraoperative blood loss estimation, and also to assess the perioperative hemoglobin and tract cell volume fall, and also for the need for additional nutrotonic agents or any need for blood transfusion. So the primary outcome was the assessment of intraoperative blood loss in both the arms, and the perioperative hemoglobin fall, and also for the need for any additional nutrotonic agents that were given according to the surgeon's discretion, depending upon the blood loss that he or she might have faced. And about the secondary outcome, we were looking for a kind of subgroup kind of analysis, where we had a comparison among the groups where there were patients who were at a higher risk for development of PPH, mainly owing to other associated risk factors such as obesity, or maybe a overdistant uterus due to a big baby, macrosomia, or fibroid uterus, or a grand multipara, or a previous history of PPH. All these conditions put the patient at even a higher risk than the other women. And so then a subgroup analysis could be assessed amongst these two groups, and what were the findings in these two groups of low risk and high risk was also to be assessed. And how many people actually had blood loss more than 1,000 ml, what was the need for blood transfusion, and definitely we looked at the side effects of drugs and the overall operating time. And this was a randomized controlled trial, and because of the differences in the administration of the two drugs, one was sublingual and the other was intravenous, we could not actually blind the study. And this was conducted in our hospital in the years 2013, 2014. This was a tertiary care maternity center, which actually had about 200 to 250 deliveries per month. So the study subjects were all pregnant patients who had undergone cesarean section consecutively in the group. And we included those women who were actually consenting towards the study and between the age groups of 18 to 39. And we took up all cases of cesarean sections, irrespective of the indication, be it previous cesarean, or maybe even harboring the high risk factors that I had mentioned earlier, or with associated comorbidities like gestational diabetes mellitus, or hypertensive disorders, or maybe even antepartum hemorrhage. We definitely excluded multiple pregnancies because there the timing of giving the medications would actually had differed, and they themselves had a separate risk for development of PPH. So then we did not include these in our present study. And any patients who had associated renal or hepatic disorders, because this would actually be affecting the drug metabolism. And any known thromboembolic or bleeding disorder patients were also excluded. And especially cesarean section under general anesthesia could not be included because patient would have had to have take the sublingual tablet when she was conscious enough. So then the cesarean sections under general anesthesia could not be included. And any known hypersensitivity to misoprostol or tranexamic acid were definitely excluded. And the dire emergent cesarean sections, that is category 1 emergency cesareans, were also excluded. And we came up to a sample size based on previous studies, especially by Suri et al., where they had compared the misoprostol versus the standard treatment and the reduction in blood loss. And we brought out a sample size that at least 66 patients should be present in each of these groups to get at least a difference of 50 ml of blood loss between the two groups with a power of 90% and an alpha error of 0.05. So finally, we had collected data about 163 patients after considering all the inclusion criteria and exclusion criteria. And then we randomized them into two groups. And the first group, the randomization was computer-generated, random numbers were used, and intravenous tranexamic acid was given to one group of 500 milligrams, versus the other group received the sublingual misoprostol, which was PGE1, 600 micrograms. And they were actually 81 patients and 82 patients respectively. Both of these drugs were administered after the cord clamping. And the parameters that we assessed were the visual estimation of the blood loss, which is considered to be quite a good standard for actually assessing blood loss, especially during cesarean section. For this, we actually assessed the weight of the used mops and also the volume that was sucked into the suction bottle. And it was definitely looked for that we did not include the Leica volume into the volume estimation. So we used separate mops for these after the delivery of the placenta, and also the suction bottle was the separate suction bottle was actually used to actually measure the volume of blood that was sucked into it and to assess the blood volume. And the mop measurement gave a rough estimate as to 1 gram of change of the weight of the mop equal to 1 ml of blood loss. And also the preoperative and the postoperative, that is around 48 hours, hemoglobin and the Paxil volumes were also assessed, and we went ahead with the study. So looking at the baseline characteristics, as our randomization was proper, there were not many significant differences between the two groups regarding the baseline characteristics. The age, the median age was around 27 years. The weight of the patients was around 72. And the pre-operative hemoglobin was also not different between the two groups. And this shows the randomization was proper. And the indications, the majority of the indications, nearly 40% were previous cesareans, and whereas the other indications were equally spread out between the two groups. And looking at the subgroups of whether high risk factors were present, it was present in nearly 45 to 50% in the two groups, and the unequal amount were absent. But then these risk factors are also equally distributed amongst the groups, so there were no confounding factors available. Now coming to the estimation, when we looked at the intraoperative blood loss, what was found was that the tranexamic acid and the PGE1 groups, there was nearly about only 20 mLs of blood loss that was found. and there was no statistical significance in the blood loss between the tranexamic acid and the PGE1. But then when we looked at the subgroup of those patients who were of low risk or who lacked the risk factors, there was almost a 90 ml difference where tranexamic acid significantly reduced the blood loss compared to the PGE1. Whereas in those patients who had risk factors for development of PPH even prior to the cesarean, there the PGE1 actually reduced the blood loss, but then that was not that much significantly associated. This was probably around 50 ml of reduction. Looking at the other parameters, the fall in hemoglobin and paxil volume were also not significantly different. The operation time, although 5 minutes more in the misoprostol group, was actually found to be significant, but the surgeons did not find a qualitative increase in time overall. And in the number of patients who required additional uterotonics, there was also not much of a difference, with nearly 30% of patients requiring additional uterotonics. This is in addition to the usual oxytocin that was given as standard to both the groups. So the oxytocin infusion that was standard, that was actually given to both the groups, and only those patients who required additional oxytocins or maybe prostaglandins, EGF2 alpha or methyl ergometrin were actually considered as additional uterotonics. But what is to be considered significant here was there were no major side effects, including the development of thromboembolism was not detected in the group, especially in the tranexamic acid was not detected. But whereas minor side effects in the form of nausea, vomiting, and even shivering on table was significantly higher for PGE1 group, nearly 62% had increased minor side effects with PGE1 compared to the tranexamic acid. So what we could infer from these findings was that although there was not much of significant difference between the two groups, in the uncomplicated primary cesarean section where they were at low risk for development of atonicity, tranexamic acid fared better, because in these groups, the PPH or the blood loss that was actually only owing to the surgical trauma, not to the propensity for atonicity in them. Whereas in those patients who had high risk factors, especially with the history of previous PPH or fibroids, there were interplay of multiple factors, including the surgical trauma and also the propensity for atonicity in them. So in them, although misoprostol had a slightly increased reduction in the blood loss, it was not statistically significant. When we reviewed literature, which actually came up much later than our study, and especially in the last years, we had an RCT of by Dawood et al., who actually looked into the same kind of population, where they compared the tranexamic acid and PGE1 with much higher number of sample patients of 315. And here they looked specifically into those patients with high risk factors, and both tranexamic acid and PGE1 had similar results in reducing the blood loss. And they also had a third arm, which had only the standard oxytocin. When comparing to that standard arm, both tranexamic acid and PGE1 significantly reduced the blood loss during cesarean section, with no difference between these two arms each. And also, in the recent meta-analysis by Chima et al. Included nearly about 50 RCTs. Here, tranexamic acid was the main drug that was studied. And of these RCTs, only 6 included high-risk people, and also 2 RCTs compared tranexamic acid with other prostaglandins, as we had done in our study. So here, tranexamic acid compared to the standard arm definitely reduced blood loss much more significantly than the routine measures. And even in the high-risk population, the tranexamic acid definitely had a good role. But then the comparison with prostaglandins did not yield very conclusive results, because their different RCTs gave different results. So to conclude from our study, the definitely prophylactic intravenous tranexamic acid as well as sublingual PGE1, they fared equally in reducing the blood loss during cesarean section. And if you want to have a subgroup kind of a differentiation, if you consider low-risk PPH, low-risk patients for PPH, tranexamic acid post the cord clamping may be considered in them. And if you want to think of sublingual misoprostol in these groups of low risk, you might have to consider that misoprostol is associated with significantly higher minor side effects. So to recommend, till now, because of the differences in the studies and the meta-analysis, the prophylactic tranexamic acid has not come up in a big way in all the guidelines. We still follow the routine oxytocin standard treatment as the prevention method in even cesarean section, but tranexamic acid definitely has got an important role to play. So maybe we need to actually put forth the tranexamic acid intravenous prophylaxis more into the guidelines and also into all cases of cesarean sections, especially in those areas where this is freely available. Again, we need to look at studies to actually find out what is the ideal timing, whether to give tranexamic acid prior to the incision itself or after part clamping would be enough, and also to assess the dosage of tranexamic acid, because there are different studies quoting 500 milligram versus 1 gram of tranexamic acid versus the oxytocin. And again, if we have sublingual, that is PG-even availability in instead of tranexamic acid in any low resource setting, to please to consider prophylactic sublingual PG-1 if it is available, especially in those high risk people who are at risk for development of PPH, and these people may require additional uterotonic support. So PG1 is definitely going to reduce the blood loss compared to the oxytocin alone. With these recommendations and these references, I thank you all for your patient listening. And if there are any questions, I would like to attend to them. Thank you.
Thank you so much, Dr. Deepak, for an excellent presentation. So any questions from the audience side?
India. My topic is effects of metformin in treating polycystic ovarian syndrome among women in tertiary care setting, a prospective observational study. Next. Introduction. Overview of disease, a most common endocrine disorder affecting 15 to 20% of women in reproductive age. Major symptoms include features of hyperandrogenism, menstrual irregularities, and polycystic ovaries. Leads to complications like obesity, insulin resistance, risk to diabetes, sleep apnea, mood disorder, etc. Role of metformin, established as insulin sensitizing agent, to improvement of the menstrual irregularities and reducing the androgen levels in some studies. Aim and objectives. Study aims evaluate the efficacy of metformin in improving clinical and metabolic profiles in PCOS. Specific objective, assess the impact on BMI, fasting insulin, and androgen levels. Evaluate improvement in menstrual regularity and ovulation rates. Methodology, study design is a prospective observational study. Population 100 women diagnosed with PCOS as per Rotterdam criteria attending gynecological OPD. Two groups. Group A, 50 women treated with metformin 1500 milligram per day, and Group B, 50 with receiving only lifestyle modification and diet modifications. Duration of study, February 2019 to January 2022. Statistical tools, descriptive statistics, Keynote test and significance p-value have get 0.05, 0.05, less than 0.05. Statistics. Inclusion criteria, those who have diagnosed PCOS using Rotterdam criteria, BMI more than 25, and normal blood glucose level. Exclusion, BMI less than 25, type 2 diabetes, pregnant women, prior treatment with PCOS-related drug, and history of bariatric surgery. Results, demographic and baseline characteristics. Age and BMI, mean age 25 years, comparable BMI more than 25 across the groups. Baseline difference, fasting insulin, testosterone, LH, similar across both groups. Start. Hormonal and metabolic parameters, significant reduction. Results in key outcomes, hormonal and metabolic parameters, significant reduction in fasting insulin in Group A from 11.97 to 7.44 milli-international unit per milliliter. LH and LH-FSH ratio have also decreased significantly in the metformin group. Reduction in testosterone level group A from 0.67 to 0.59 milli-international per milliliter. Menstruation and ovulatory outcome, improvement in menstrual regularities in 62% improvement in group A versus 25% in group B. Ovulation restored in 30% in group A compared to the 18% in group B. A discussion, impact of metformin, weight and BMI, no significant weight change in group A aligned with the prior finding. And menstrual regularity, metformin shown improvement menstrual pattern, though less effect in ovulatory dysfunction. Androgens and insulin sensitivity, notable reduction in insulin resistance and androgen levels. Study limitations. It is a single centered study, limited sample size, possible regional biases, lack of randomization, group assignment by convenience may be impact finding, unmeasured comorbidities, other PCOS-related health issue not controlled or measured. Conclusion and future recommendations. Metformin demonstrate efficacy in improving hormonal balance and insulin sensitivity in PCOS. Minimal impact on weight and physical symptoms, hirsutism, acne. Future recommendations, conduct larger multi-center randomized studies, including broader parameters such as vitamin B12 levels and adherence to the lifestyle modifications. Thank you.
Thank you, Dr. Suresh, for the presentation. So any question from the audience side?
Adenoids and pharyngeal tonsil are normal lymphoid tissues present in the posterior wall of the nasopharynx. This constitutes the upper portion of the Walder's ring, and that is important site for first contact for inhaled allergens and microorganisms. So the growth of adenoid tissue is not in agreement with that of the bony nasopharynx and is manifested as obstructive symptoms. The adenoids appears to be at its greatest size during 7th year and regresses thereon, and at the age of 15, the patient almost have nil symptoms. The most common presentation of adenoid hypertrophy is nasal obstruction, mouth breathing, snoring, obstructive sleep apnea, anterior and posterior nasal discharge, night cough, craniofacial developmental disorders, speech disturbances, lethargy, behavioral disturbance, poor academic and scholastic performance. The predominant cause of pediatric OSA is typically adenotonsillar hypertrophy, thus making adenotonsillectomy as the initial approach procedure. In determining whether the procedure should be constantly involved in removal of both tonsil or adenoid or either adenoid is still a controversy. According to the textbook of pediatric pulmonology, which holds a definitive stance, both tonsils and adenoids should be removed even when one or the other seems to be the primary culprit. However, in contrast to adenoidectomy, tonsillectomy is linked to a higher chance of complications and morbidity. So, the complications following adenoidectomy are extensively common, with few, if any, being life-threatening. Mainly, bleeding is the life-threatening complication, but there has been only limited investigations into the scope of adenoidectomy alone as a standard of procedure in treating obstetric sleep apnea. Most of the studies are concentrated on treating adenotonsillectomy as the primary procedure for OSA. In this context, my study, I will tell you what are the aims of the study. The aims are to study the pre-operative signs and symptoms in children with adenoid hypertrophy, to compare the pre-operative symptoms with postoperative symptoms to study the change in the quality of life after adenoidectomy, to study the effectiveness of adenoidectomy alone in treating the patients with OSA. This study was a multicentric study which was conducted in June 2022 to 2023 in ICRA Hospital, Calicut, and Head and Neck Oncology Smitha Memorial Hospital, Thodupuzha. The informed consent were obtained from the patients' bystanders. Next, I'll be moving to the inclusion and exclusion criteria. Inclusion criteria are children in the age group 5 to less than 10 years of 10 years at the time of screening. The prenatal reports and symptoms of adenoid hypertrophy or habitual snoring, apnea, choking, rhinitis, tonsillar hypertrophy less than 2 was also be considered, because greater than 3 with symptoms we need to do tonsillectomy on another scale. Next is the candidates who are candidates for adenoidectomy as if by endoscopy or other means. Which are the patients which are included in the exclusion criteria are children with history of previous adenotonsillectomy, nasal polyp, congenital anomalies like Down syndrome, syndromic associations, developmental delays, autism, or mental retardations were excluded from the study. Those children who are undergoing any concurrent procedures along with adenoidectomy were excluded from the study. Children who underwent simultaneous tonsillectomies like recurrent tonsillectomies, that is according meeting the criteria, that is 7 episodes in a year or 5 episodes in 3 years or 2 episodes every year, were also excluded from the study. Next is that the patients who are not willing for the study was also being excluded. For assessing the quality of the life in patients with adenotonsillectomy, pre-op and post-op, OSD 6 criteria was being adopted. This questionnaire has got 6 scales, and 0 was the minimum and 6 was the maximum depending upon the severity. And this is the questionnaire. The questionnaire, so excuse me. No. Excuse me. Hello.
Yes, doctor.
Someone else screen is being shared with me. Someone else screen is being shared with me. Sorry.
Hello.
Dr.
Am I audible?
Urosa. Yes, please stop sharing, Dr. Urosa.
Am I audible?
Yes.
Am I audible?
Yes, we can hear you. Please stop sharing.
Basically, I'm from doing it by phone. So
Hello. Hello.
Yes, doctor. Now you shall
Yeah.
proceed. Sorry.
Hello. According to the questionnaire, physical disturbances, sleep disorders, speech and swallowing disorders, emotional distress, limitation in the activity of the child was being taken into considerations, and the score was being proposed. This is basically the grading of tonsil. Grade 1 is grading of adenoid, which was graded into 4. In our surgical protocols, the grade 1 is less than 50%. Grade 2 is the adenoid tissue filling from 1/3 to 2/3 of the choana. Grade 3 is from 2/3 to nearly complete obstruction. Grade 4 is complete obstruction. We were analyzing our statistical data using SPSS software, and the p-value less than 0.0 was considered statistically significant. Results: a total of 48 patients were evaluated, aged between 5 and 10 years. There was 26 cases of male cases and 22 cases female children. The mean post-operative follow-up was 6 months and 1.5 years post-operatively. The DNA findings are out of the 6 patients. Out of 6 patients were having grade 1 hypertrophy, and 9 patients had grade 2 hypertrophy, and 22 patients who had grade 3 hypertrophy, and 11 patients who were having grade 4 hypertrophy. This is a data which shows. In this, we can see that there is 29 patients. Actually, we have 48 patients, but many patients will be having different symptoms, so that it is being put as 29, 22, and all. The most common symptoms was mouth breathing and nasal obstruction, and the least symptom was drowsiness. Now I am going to the result. Complete recovery was observed in 89% patients. Statistical analysis showed a significant difference for improvement in each symptoms between pre and post-operative analysis, which I'll show in the next slide. Post-operatively, 2 children were having persistent nasal obstruction, which was due to deviation of the posterior septum. Hearing loss also was present in one of the child at the end of the study. Which later we had done mergotomy and grommet insertions. Snoring and sleep disturbances were persisting in one child at the end of the study, which was actually a failure of the study of the surgery. Pre-operative and post-operative scores was calculated by OSD6 based on OSD6, which is a questionnaire which I had shown previously. None of the kids had primary hemorrhage or secondary hemorrhage. The most commonly reported adverse effect was throat pain on post-operative day 2, which recovered spontaneously with NSAID. This is the result. The physical distress pre-operatively and post-operatively will show that the p-value is less than 0.05. The sleep disorders also improved. Speech and swallowing disorders improved. Emotional disturbance, limitation in activity, all were improved. This is the chart showing the same. You can see that the most common symptom was snoring. In all these symptoms, there was improvement. Then coming to the discussion, adenoid hypertrophy and its sequelae are common disorders of pediatric age group. The major indication for adenoidectomy is sleep apnea, recurrent non-resolving rhinitis, otitis media, and rhinosinusitis. There are various measures for analyzing the quality of life in post-adenoidectomy patients, like OSS 18, behavioral assessment systems for children, child behavioral checklist, OSD 6. In this study, we have used OSS 6, which is the most popular study which we see in journals. The study concerned by our study revealed that was almost similar to the study done by Domini, except that we could not use polysomnography, and it is not practical to use polysomnography in children of the age 5 years. Children with who fall into the risk cluster defined by large tonsil and higher AHI greater than 10, the success rate of adenoidectomy alone is inferior to that of adenotonsillectomy, resulting in higher rate of treatment failure. Hence, based on the findings present in the study, group of pediatric patients in the OSA who had less OSA, that's less than 10, and Brodsky's criteria grade 2 is an indication for doing tonsillectomy. Compared compared to adenoidectomy and adenotonsillectomy is associated with significant increase in the mortality. So avoiding adenotonsillectomy together than adenoidectomy would be better. Then coming to the limitation of the study, the major limitation of the study was the short period between just 1 year, and the number of sample size was 48. The surgery was done by the same surgeon. Multiple surgeons would have multiple surgeons, and multiple centers would be better. And these are my references. Thank you. Thank you.
Yes, thank you, Dr. Fabin, for the wonderful presentation. So, any question from the audience side?
Hello.
What is nutrition? Nutrition is derived from a Latin word, nutri, meaning to suckle or feed. And some researchers have said that it is derived from a Latin word, which means nourishment. Proper nutrition can help us improve our health, prevent certain disease, and achieve and maintain a desirable weight, and maintain our energy and vitality. Nutrition is particularly important in early childhood when the growth is most rapid. Therefore, children below, under 5 children are most susceptible to malnutrition. Nutritional status of child may fall anywhere along continuum from healthy to imbalance. And this imbalance includes both inadequate and excessive energy intake, which in turn leads to malnutrition. Growth can be determined by measuring the body weight and height. A child at a particular age must have a specific height and weight. In other words, body weight and height of the children can become the indicator of his or her nutritional status. There is a second method, that is dietary intake, the second method of assessment of nutritional status of a child. And nutritional status of a child can also be assessed on the basis of clinical signs and symptoms of various nutritional deficiency diseases. Presence of one or more deficiencies will mean poor nutritional status. Child suffering from protein energy malnutrition is shorter and thinner as compared to other children of same age. If we will see 6 reported global nutrition showed that the extent of malnutrition is still high and progress to reduce it in most regions of the world is very slow. Globally, we have 151 million under 5 children who are stunted, and 51 million who are wasted, and 16 million who are severely wasted, respectively. And 38 million under 5 children were overweight in 2017. As per NFHS 5, National Family Health Survey 5, which was carried out in the year 2019 and 2020, in India, we have 35.5% under 5 children who are stunted, 19.3% were wasted, and 32% were. The change in nutritional status across the Indian states has been it's variable. From state to state, it varies. And in the state of Jammu and Kashmir, situation has not undergone significant, there is no significant change over years. With the current prevalence of stunting, wasting, and underweight, we are having 31%, 7.1%, and 15% respectively. Problem of undernutrition is now supplemented by the challenge of growing population of overweight and obese children, which has been reported to be 4.3% and 15.3% respectively. Present study was done in order to assess the magnitude of malnutrition and factors contributing to the same in the under 5 population and health block, Hajin, which is the rural free practice area of community medicine. My aims and objectives were assessment of nutritional status of under 5 children in block Hajin, which is rural area, and to identify the factors associated with the malnutrition in these children. Material methods. Study area was a block, which is the rural free practice area of community medicine, near about 30 kilometers away from Srinagar city, the center. Then study design was a cross-sectional and community-based study. Study period, it was carried out for a period of 1 year, that is June 2017 to June 2018. And study population were all under 5 of age, whose mothers consented and were the permanent resident of the health block, who participated in the study. Inclusion criteria: under 5 children whose parents, guardians gave consent to be the part of the study, we took them. And exclusion where children under 5 whose parents and guardians didn't give consent to be the part of the study were excluded. And moreover, children with documented congenital defects, developmental delays or abnormalities, mental retardation or metabolic syndrome were excluded. My sampling technique was multi-stage random sampling technique, assuming an overall prevalence of underweight, weight for age less than median plus minus 2 standard deviations or WHO standards of 50% among under 5 children, with 5% absolute precision and confidence interval of 95%, which included non-response rate of 5%. Sample size: a sample of 403 for the study was calculated as per formula N is equal to Z square P 1 minus P divided by D square, where N is estimated sample size, Z is statistic for 95% confidence interval, and which values 1.96, and P is expected prevalence, and D is absolute precision. Sampling procedure: study was conducted in Hajin, having total population of 2,10,946 according to census 2011. The study sample 403 was drawn randomly from 3 zones of block using multi-stage sampling technique based on probability proportional to size. A written informed consent was taken from parents, guardians of the participating under 5s, and necessary information gathered from them, following which relevant experiment examinations was done on the study participants based on the pre-test questionnaire. Questionnaire included questions pertaining to the general characteristics, besides information on anthropometric measurements and relevant clinical examination. Ethical clearance was approved by the Institute's ethics committee, that is SKIMS, and data analysis. Data was collected by subjected to descriptive analytical statistics using SPSS, that is for social science. And appropriate statistical tests were applied where needed. So going to the results, if we will see this table 1, it shows that belong to the age group 25 to 60 months, followed by 7 to 24 months, they were 36%, and less than 6 months were 18%. And if we will see more than half, that is 54% of under 5 children belong to female gender. As per the birth order, we were having most of the children, 40.9% belonging to birth order 1, followed by birth order 2, 32%. And regarding birth interval, near about 40.8% of children were having birth interval of 25 to 36 months. And regarding birth weight, more than half, that is 56.6%, were having the birth weight of more than or equal to 2.5. Coming to the next table, shows the nutritional status of the study published by anthropometric indicators. First of all, we just calculated a weight for age. In this, we can see 85.4% were overall having the normal weight for age. Children were having normal weight for age. And if we will see overall underweight, we can see maximum children who were underweight belonging to the age group less than 6 months, initial 6 months. 27.4%. As for going for height for age, that is stunting, we can see 89.3% of children under 5 were normal. And if we will see overall stunted, we can see maximum of children who were stunted belong to the age group of 25 to 60 months. Going for weight for height, that is severely wasted, that is acute malnutrition, we can see near about 85.6% of under 5s were normal overall. But overall wasted in that column, we can see that maximum of wasted children were seen in the age group of less than 6 months. This is the figure showing nutritional status as per mid-upper arm circumference. As you can see, 72.2% were having this satisfactory nutritional status, then followed by 25% having mild to moderate malnutrition, followed by 2.1% having severe malnutrition. I may conclude by saying that the prevalence of different forms of malnutrition was comparatively lower as compared to national data. It was having a better, nutritional status is better in Jammu and Kashmir. Malnutrition was more in infants, female gender, under 5s belong to the nuclear families having illiterate mothers, and those belong to the lower socioeconomic status. This portion I have shown in, this was a BRIC project. So I have one more paper in that I have shown all those socio-demographic data. Recommendation: nutritional education should always be employed a wide range of hands-on teaching, learning methods. It's an important element in overall strategy aimed at improving food security and preventing all forms of malnutrition. Preschool and Anganwadi, more I can say, emphasis can be given at the Anganwadi centers. They are the ideal settings for promoting lifelong healthy eating habits and lifestyles, as they cater the population under 5 children. Nutritional surveillance needs to be done continuously, and special attention should be given to vulnerable groups such as poorest and the most severely malnourished. Thank you.
Thank you so much, Dr. Rosa, for the presentation. So any questions from the audience side?
Hebrew University and Hadassah Medical Center, where I serve as a professor of obstetrics and gynecology. Our specialty, obstetric, is a unique in medicine. We treat simultaneously 2 patients, the pregnant woman and the fetus, and when sometimes conflicts appears by this in the treatment. When we are speaking of assisted reproduction, there is two or even more parties, mainly the society, that with the development of assisted reproduction, conflicts with the new developers are observed. In order to define the status of the embryo its moral status, legal status, and even biological status, we need to know when human life begins. It is well known by the biologists and by the physicians that human life begins at fertilization, when it takes place in vivo, natural, or by assisted reproduction in vitro. Fertilization has several steps until the sperm in vivo or in vitro enters the nucleus and forms the zygote. Zygote development in vivo or creation takes place in fallopian tube, where the embryo is dividing for 5-6 days, forming morula and then blastoza, and after this time enters the uterine cavity for implantation. In vitro, we usually transfer the embryo on day 3 or on day 5 when it is a stage of blastocyst. The important point of have a successful pregnancy in both techniques, vivo and vitro, is the success of implantation, which takes usually at days 14, 15, or even 13. The embryo stage of implantation is in gastrula stage, or the process is called gastrulization. Is early development process in which an embryo transforms from a one-dimensional layer of epithelial cells, blastula, and reorganized into multi-layer and multi-dimensional structure, as you can see in the slide. So, if implantation is successful, then pregnancy starts. The definition of pregnancy is interesting to see, was done in 1998 by Ethical Committee of World Physicians or OBG people in FIGO. I chaired at that time the committee of FIGO Ethical Committee. Pregnancy is that part of that commences with implantation of the conceptus in a woman and ends with either the birth of an infant or abortion. There is not consensus, as you can see in the slides, about when human life begins between physicians, biologists, theologians, philosophers, ethicists, and so on. Already 300 years before Christ, the Greek philosopher Aristotle believed a fetus in early gestation has a soul, of a vegetable, then of animal, and only later become animated with a human soul by ensoulment. For him, the ensoulment occurred 40 days after conception for male fetuses and 90 days after conception for female fetuses. But these scientific arguments, which show that the embryo starts with formation of the zygote, is based on the genetic view. A beginning of human life is at the fertilization. A new combination of genetic material is created for first time. Thus, the zygote is an individual unit from all others. But even this statement is not acceptable by all scientists due to the twinning arguments. What it means, twinning arguments? It is possible for the zygote to split into 2 or more zygotes up until 14 or 15 days after fertilization. Therefore, the zygote has not completed the process of individualization. It is not ontological individual. The neurological view. As is known in medical practice, death is a complete and irreversible loss of brain function. Life and death should be based upon the same standard of measurement. Then, if death is based of irreversible loss of brain function, then the beginning of human life should be recognized as the time when the brain activity is detected. The first appearance of the neurological tissues, the primitive strict forms, are observed in day 14, which at present days can be observed by ultrasonography, and therefore, from the neurological point of view, that starts the brain activity. So, as I mentioned in previous time, no longer using human embryos in experimental studies is permitted because the life already started. Ecological technological view. It is accepted when an individual can exist separately from the environment in which it was dependent of development. It is the mother womb. The limiting factor for the human viability is not the development of connection between the maturation of the lungs, and therefore only an individual existed outside of the womb means the life starts. Some legislation using this ecological technology view of when human life begins, criteria for abortion legislation. Philosopher view. According to the philosophers, the zygote, neither the zygote, nor an embryo, or nor a fetus is a person either. Only a person, according to philosophers, are the moment when the individual, the human child, gains consciousness. At this moment, not at birth, should the child be considered a full-fledged person entitled to all the rights that human adults are entitled to. The religious influence on reproduction, especially on assisted reproduction, is influenced by religion. Religion still has a big power in society, greatly influence individuals. It changes behavior and practice of individuals, and what is important, it may change behavior of policy making individuals which make the rules, mainly of rules relating to reproduction and at present days to assisted reproduction. From the religion point, let us start with Jewish perspectives. The beginning of human life, the Jewish perspective is based on halakha. It means to go. The halakha, the main book, is the Torah, given to Moses on Mount Sinai. And in halakha is determined when when embryo or fetus is a human being. It is a description of a condition in Exodus 21 when people were fighting and injured a pregnant woman. The injury resulted in abortion. In this case, what is written in the Bible in Exodus means the people who fight should pay penalty to the husband, but though it is usually in the Bible that if you lost a life, you need to pay for with life. This is a conclusion that according to Torah, fetus is not a human being. In Mishnah, written in the century, regarding the fetus, an unborn fetus in Jewish law is not considered a person. In Hebrew, it means nefesh, soul, until it has been born. In another writing, Talmud, 6th and 7th century, the interpretation of the previous commandments of Torah and so on is first time mentioned. A fetus under 40 days is considered as bare water. From 600 till now, the Jewish observe the religion or depending on question and replies by rabbinical authorities. It goes so on from 600 until now. Christianity. According to Christianity, its unique idea, human life begins at conception. It has big influence on the woman life and independence, and is very well known today, even in the political life, regarding the laws of induced abortion, even seen in the last abortion in states, that it was one of the main issues. The Christianity Bible has two sections, the Old Testament and the New. The Old Testament is the origin of Hebrew Bible, the sacred scripture of the Jewish faith, written at different times between about 1200 and 165 BC. The New Testament books were written by Christians in the first century. According to some ideas or meanings, from where it comes that according to Christianity, the zygote is a person. A person, let us say the human being, that it is not allowed to destroy, and you need to look at it as human being. It comes by a mistake of translation of the Bible by Jewish in Alexandria in the 100 of post-Christ, when there was mistake with what is written in Exodus 21, when I mentioned the story of a pregnant woman that was involved with a struggle by a man, and the pregnancy resulted with abortion. There was a mistake done by translation from Hebrew to Greek, only by one word, because what it means in the original one, it means that the fetus was destroyed, was abortion. You don't need to pay life for life. Why is the translation? The word was a substitute of fetus with the man. So the word man is interpreted by the sages to mean man, but not the fetus. Thus, the destruction of an unborn fetus is not considered murder. Islam. The main writings are Quran and the Hadith, authentic tradition and saying of Prophet Muhammad, first 3 century of Islam. A good Muslim resorts to secondary sources of Sharia in a matter not dealt with the primary sources. According to Islam perspective, the development of the human embryo advanced from a clot to a lump of flesh, then bone flesh, and finally a fully grown infant. The general Islamic view is that although there is some form of life after conception, for human life begins only after the ensoulment, 40 or 120 years. Most Muslim scholars, including the Shia, believe that the ensoulment occurs as about 120 days after conception. What is the moral status of the embryo? There are 3 options for a definition. 1, the pre-embryo has no moral status. It is collected of undifferentiated cells. The second opinion is the pre-embryo has the full status of a human being. The one accepted today is that the pre-embryo is a potential human being, a definition that is comprised between the other two. The moral status of embryo. Just after conception, a zygote has little more status than the sperm and eggs. But as the embryo develops, its moral value increases slowly and steadily. Thus, while at 6 or 8 weeks, embryo might have very minimal status, but a fetus at age 32 or 35 weeks have virtually identical moral status as a newborn. It should be taken into consideration in legislation of induced abortion and is taken into consideration in practice of obstetrics. At present, go further, the legal aspects of the embryo. Embryo are not legal subjects unitus, but indeed share the legal subjectivity of their parents. As you probably know, in 1978, 40 years ago, Edwards and Steptoe brought to life the first in vitro fertilized baby. Scientific progress and rise to society conflict. Already with this achievement of Steptoe, there was a protest of the society to introduce the assisted technology for medical practice. How the medical profession deals with the question of the embryo? It deals by establishing international medical ethical committees. I have the privilege to chair the main ethical committees of the main OBG bodies, like the FIGO Committee for Ethical Aspects of Human Reproduction, the Eastern International Federation of Fertility and Society, and the World Association of Perinatal Medicine. From a legal point, who decides how to manage assisted reproduction or anything what is dealing with the embryo before transfer, freezing embryo, and practice at all? It is done by regulation in most countries by Ministry of Health or by decision of courts. In many developed countries, especially Europe states, Australia, it is done by legislation by parliaments. At present days, we face advanced reproductive technology develops in order to make the assisted reproduction and the fate of the embryo better, like possibility to make studies on embryos after 14 days of pregnancy, possibility of genetic engineering, which helps the individual baby, even the possibility to establish an artificial womb, and even we are looking on the possibility live on womb. As I already mentioned, implantation takes place a day after 12 to 14 days starts, and to study implantation is of very big importance, as I will mention. There was a new development in September 23. At first time in the laboratory, it was possible to grow a synthetic embryo model, a structure that has placenta, yolk sac, and other external tissue of age of 12 to 14. It was done by Israeli professor, a graduate of our medical school in Weizmann Institute. But the question was why he stopped at the day 12, 13 and not continue to make the studies after 14. Because there is, as I mentioned, the 40-day rule, which started with the UK Warnock report in 1844, when the first baby by Steptoe and Edward brought to life. This rule is called the 14-day rules. No embryo should be cultured in vitro for research purpose beyond 14 days. Most countries has adopted the rule. What is important to study the stage of development after implantation? Study of early stages of embryonic development is of our importance to look for cases of early abortion, formation of malformation. It can give us idea and knowledge of the effect of drugs and other chemical agents on embryonic development, study genetic manipulation, and even embryos can be used to grow organs for transplant. At present days, the ethical medical committees, according to the conflict that exists between the advanced research in reproduction, assisted reproduction, and the society statement, to extend the research period for embryos to 28 days after fertilization. Integrate embryos like structure, synthetic embryos that we are able today to form should be currently given the same moral status as natural embryos. If somebody is interested in the subjects that were presented, you can read some of my books that I edited. Thank you for your attention.
Thank you so much, Dr. Joseph, for the presentation. So any question from the audience side?
STIs. For Ghana, in 2020, teen motherhood hit record high. However, we have regional or rural-urban variation in teen pregnancy. And the estimates show that 301 adolescent girls get pregnant every month, and then 13 get pregnant every day. The data also show new cases, that's increasing new cases of HIV in Ghana. When we look at the policy environment for sexual and reproductive health, would say that Ghana has adequate policy environment, and there are adequate policies for promoting adolescent sexual and reproductive health. And most of the policies focus on information, access, education, and services. However, there is limited access to information. So that's a contradiction between the policy and what is actually happening on the ground. And there is also a problem with cultural values and then the issue of stigma. So while adolescent sexual and reproductive health policies in Ghana feature education, that's education on sexual and reproductive health prominently, there is limited scholarship on information access among adolescents, literacy, and also little studies are done among young adolescents, even though we see upsurge in pregnancy among young adolescents. For this study, we look at sexual and reproductive health literacy. And the issue is that once the focus of most policies on adolescent sexual and reproductive health literacy center around education and information access, then literacy is very important. In other studies, literacy have been found to be essential in reducing early pregnancy and then recurrent pregnancy among adolescents. And among young adolescents, it is also valuable in providing understanding of physiological changes in their bodies and also shape their sexual behavior. It's also useful or a useful antecedent in promoting informed decision-making. So for the study objective, we wanted to gain insight into literacy and access barriers to sexual and reproductive health information among adolescents because we feel they are important, or such an assessment is important in identifying areas of intervention and also to stimulate sexual and reproductive health literacy and outcomes among adolescents. So specifically, we assess how young adolescents in the Futu municipality construct meanings into sexual and reproductive health as a concept, their knowledge gaps, and then barriers to information access. Methods. So for the study, we conducted the study in the Futu municipality, which is one of the municipalities in the central region of Ghana. And we use a narrative design and a focus group discussion method to collect data. Our population, the study population was in-school adolescents at the basic school level, those in 7th and 8th grades. And the age limit was 11 to 15 years. The study institution, as I mentioned earlier, basic schools, we focus on basic schools because basic schools in Ghana, almost 95% of all adolescents are enrolled in basic schools. So if you want to get adolescents, then it is important to look at basic schools. And for sampling, we use a purposive sampling method to sample the school. We selected 3 basic schools and then 52 in-school adolescents using the purposive sampling. So the sampling was based on religious affiliation of the school, the performance of the school in terms of their basic school certificate examination outcomes. And then we also look at consent for participation, especially parental, and then assent from the adolescent participants. We also look at the school managers and their consent. For instruments, we develop a focus group discussion guide based on an extensive literature review. And we had the focus group discussion in the school premises after school. Meetings were held separately for males and then female adolescents. And the moderators for the focus group discussion, males moderators moderated the focus group discussion for males, and then for the females, they also had female moderators. For trustworthiness of our data, we improve trustworthiness using the following criteria, that is credibility, transferability, dependability, and then confirmability. Our study was approved by the Ghana Health Service Ethics Review Committee. For the data collection, we recorded the focus group discussions, the meetings, we recorded that using audio tapes, and then we transcribed and processed the data using QDA Minor version 6. We collected data for the study in February 2022. We use deductive thematic analysis to analyze the data and draw patterns within the data. So at the end of the analysis, we established 7 main teams and then 4 sub-teams. So for the results or the findings, table 1.1 presents the participant information. The mean age of participants was 13 years. We had more females constituting 71.2% of the sample that we took, and they were both Christians and then Muslim. So table 1.2 gives us the main teams and the sub-teams that we established from the data. So for the main teams, we look at perspective on sexual and reproductive health as a concept, and it had a sub-team, sexual maturation. We look at sources of information, and then we came across accessible content, and then the literacy challenges of adolescents, contraceptives and methods, sexual behavior, and that had a sub-team, sexual maturation, then STIs and treatment, preferred sexual and reproductive health topics, and sexual and reproductive health goals of the basic school adolescents. So table 1.2.1 gives us further details of the findings. So when we look at perspective on the concept of sexual and reproductive health, how the basic school adolescent construct meaning into the concepts. Here is something from one of the adolescents says that, Madam, that they are told that sexual and reproductive health is about wearing decent dresses, so that if older people see us, we don't have a problem with them. So they will know that we are good girls. With this, no man will also have sexual feelings for us. So listening to the adolescent, then it means that even though sexual and reproductive health education feature prominently in the strategies that are outlined in the policies, the focus of sexual and reproductive health education in basic school is purely on abstinence and then maybe chastity. So for sources of information, we realized there were over-reliance on informal sources of information, and they had little access to print and online sources. So an adolescent said, Madam, we get information from our parents, teachers, and guidance and counseling people. Another said, we also get information from wise teens and older people, meaning that apart from the school sources that focus mainly on abstinence and chastity, the rest of the sources are purely informal. Then accessible content for the adolescent, most of the content that they are exposed to are personal hygiene, abstinence, and then good manners. So one of the participants said that the teachers teach us how to keep ourselves from having sexual intercourse. Another said, they said some physical, emotional, and physiological changes happen when adolescents develop. The information is in our textbook. So it also tells us that in the textbook, what they have in the school textbook is basically on abstinence and then development, that is pubertal changes. Then we have one team that says literacy challenges. That's difficult to read print and online sexual and reproductive health information. An adolescent said, yes, madam, we do not understand most of the words they use in writing them. So trying to emphasize the difficulty level of the information in textbooks, maybe online sources and some other print sources. Another said, madam, the English language use is too difficult. So then contraceptives and method. Adolescents had knowledge of short-term contraceptives and then self-induced abortion. So one said, madam, you can also do an abortion, like taking a pack of paracetamol. Others use sugar and then paracetamol with alcohol to do abortion. Unsafe methods of abortion was high among the in-school or the basic school adolescents. For sexual behaviors, adolescents had adequate knowledge about etiquettes of personal friendship and very little about risky sexual behaviors. One adolescent said, madam, in trying to explain what safe sex is about, said, madam, safe sex is when the lady avoids drunkenness so that if she gets pregnant, she can figure out the father of her child. So it means that when it comes to risky sexual behavior or safe sex, the basic school adolescent has little knowledge about that. Discussions. From the findings, we realized that sexual and reproductive health education in basic school mainly focuses on abstinence. Access to sexual and reproductive health information is mainly informal and has the potential to propagate inaccurate and unsafe information among adolescents. Only a few of the participants had access to smartphones to search for sexual and reproductive health information on the internet. Available content do not align with the literacy skills of the basic school adolescent. Major barriers are inadequate literacy skills, stigma and prejudice, and lack of access to age-appropriate but comprehensive information on sexual and reproductive health. Consistent with the literature, most adolescents in basic school are exposed to sexual relationship, making open conversation and education on sexual and reproductive health critical for the Ghanaian basic school adolescent. Study limitations. The assessment was limited only to one municipality in Ghana, and the data collection methods restricted the discussion to a limited number of adolescents, making it difficult to generalize the results of the study. There is a need for further research on the sexual and reproductive health literacy needs of young adolescents in Ghana to inform future interventions. Conclusion. The study provides an extensive description of young adolescents' conceptualization of sexual and reproductive health information, access challenges, and then knowledge gap. Almost all participants had restricted and poor access to structured and safe sources of information, except a few who had internet access. Major challenges to sexual and reproductive health information access were the lack of availability of information, the linguistic difficulty of available text, and adolescent sexual and reproductive health stigma. Young adolescents are uninformed about sexual and reproductive health as a concept, risky sexual behaviors, STIs, and then contraceptive, advocacy on community and then parental involvement, adolescent sexual and reproductive health education, and literacy at the subnational level are essential to stem the tide of prejudice and stigma and to stimulate an open parent-adolescent sexual and reproductive health conversation. It will be useful to revise adolescent sexual and reproductive health strategies to embrace actions to improve the availability of easy-to-read educational materials and adolescent health literacy. Thank you.
Thank you, Dr. Jacqueline, for the presentation. So any question from the audience side?
With pathogenic microorganisms can occur at all stages of its processing, including food preparation by consumers. So consumers have great responsibility in ensuring food safety and hygiene as well. We prepare one study related to food safety knowledge regarding consumers' food handling practices at home. And also pregnant women should pay special attention to food safety and especially during pregnancy. During pregnancy, the risk of serious consequences of foodborne illness increases for both the pregnant woman and also the fetus. And today I would like to show you some results of our study, which will be also published in Foods. Among all known microbiological hazards, diseases caused by bacteria Listeria monocytogenes and the parasite Toxoplasma gondii are particularly dangerous during pregnancy. So infections during pregnancy can have serious consequences, especially for the fetus, and can cause miscarriage or premature birth or stillbirth. Listeria can be present in raw or prepared foods and can contaminate during preparation, and also can multiply in the refrigerator at low temperature, also below 4 degrees. Toxoplasma gondii infections, this is the parasite, and it can occur by eating unwashed vegetables, insufficiently heat-treated meat, or drinking raw or unpasteurized milk. So women can also become infected with direct contact with a cat. So the aim of our study were to investigate the self-reported food safety knowledge and practices of pregnant women and also postpartum mothers using an online questionnaire. We compared these results with non-pregnant group of women as a control group, and also we compared the results with the results of similar study by Gunneri and co-workers, and by our study, which was done in 2008. So here we can see the demographic data of survived population. We have numerous of women included in the study, 426. Among that, we have non-pregnant women, pregnant women, and postpartum mothers. Non-pregnant respondents are younger and less educated compared to the other respondents, and there is no significant difference between the subgroup of pregnant and postpartum respondents in this regard. So the results regarding food safety risk show that pregnant and postpartum women have a higher awareness of food safety risk than the group of non-pregnant women, while there is no significant difference between the pregnant and postpartum subgroup. The rate of consent to eat risky food during pregnancy is similar. Consequently, non-pregnant respondents are more likely to report preparing these types of dishes than the pregnant and postpartum group. What is good, because we know that the period of pregnancy is especially risk for preparing raw food containing raw meat or raw milk. Lower awareness is observed in relation to bacteria Listeria monocytogenes, where only slightly more than half of pregnant respondents are aware of it. And only 1/3 admit that they do not know if there is an increased risk of infection during pregnancy from Listeria. So we have to have more education regarding pregnant women. While there is no influence, here I will present the results regarding hand hygiene, and table 3 is related to compliance rate in hand hygiene occasions, hand hygiene technique, and hand-borne diseases after toilet use by maternity status. While there is no influence of maternity status on the recognition of occasions requiring hand washing and the washing technique itself, the pregnant group most frequently recognizes gastrointestinal diseases as a consequence of not washing hands after using the toilet. In table 4 are results related to food purchase. So frequency of checking food characteristics and storage and hygiene conditions when purchasing food by maternity status are listed from highest to lowest overall arithmetic mean. And you can see at the left some conditions and answers of different group of women. The conditions of the packaging receives the greatest attention, and the refrigerator temperatures receive the least attention from the respondents when buying food. What is not good, because we know that perishable food must be stored at low temperature below 5 at home refrigerator, and especially when we purchase our food, we must also look at the conditions in retail shops. Except for declaration and refrigeration temperature, pregnant respondents pay the greatest attention compared to the other two subgroups, but this was not significant. In table 5, we present the compliance rate regarding food storage practices, also by maternity status. So the compliance regarding proper food storage is generally higher in the pregnant and postpartum groups than in non-pregnant group. What is also good, because pregnant women have awareness regarding food storage conditions, and the largest and significant difference is observed in the context of avoiding cross-contamination in the storage of cooked and raw foods, where the non-pregnant indicate more risk practices. And also when considering the storage location, for example, of milk, the postpartum group differs significantly from the other two subgroups. Our results regarding food preparation are presented in table 6. Our arithmetic mean of self-reported practices related to cross-contamination prevention by maternity status are listed also from highest to lowest overall mean. And self-reported practices show us selective prevention of cross-contamination, especially by cutting boards, while the frequency is highest when washing the cutting board after cutting raw meat and before cutting heat-treated meat. We can also observe the lowest frequency when separating the cutting board for raw meat and raw vegetables. We found the largest and significant difference in relation to hand washing after handling eggs, where the non-pregnant women report a riskier practice. And we were also happy because pregnant and postpartum group of women handling more properly with eggs. Similar results were also obtained in our previous study in 2008, with differences in mean scores showing that pregnant women believe more strongly in relation to non-pregnant group in washing their hands thoroughly after handling eggs. So when we further asked if they agreed with keeping raw meat and raw fish separate in the refrigerator, the pregnant and postpartum subgroups agreed with this statement less, only 11%, than the non-pregnant subgroups, where we have 16%. About 50% of the pregnant and postpartum subgroup and also 40% of the non-pregnant subgroup disagreed to that. We have also some not so good practices regarding thawing raw food on the kitchen counter. And this was most commonly reported practice among all respondents. 2/3 of respondents said that they thaw frozen food on kitchen counter. But it was reported more frequently by the non-pregnant subgroup. The ratio was here higher regarding the pregnant and non-pregnant group. However, the majority of all respondents also fully agree that thawed meat should not be refrozen. So our conclusion are that the results indicate that pregnant women generally have basic knowledge of food safety and proper food handling, but we discovered some gaps. We also discovered some food handling gaps regarding food safety in 2008. They not pay attention to avoid cross-contamination when storing cooked and raw foods. They thawing raw foods on the kitchen counter and washing hands after handling raw eggs and preparing baby food or breastfeeding. But the group of control group don't handling with raw eggs right. We also found out that 77% of pregnant women are aware that they have an increased risk of infection with Toxoplasma gondii because media also a lot described regarding this kind of risk, while only 34% of pregnant women pregnant women do not know whether they have an increased risk of infection with the Listeria monocytogenes during pregnancy. These results show that pregnant women, when we compare group with postpartum, have slightly better results, and both groups have significantly better results than non-pregnant group. Because of that, we prepared some material for education for pregnant women and postpartum women regarding hygiene of expressing and storing breast milk and formula milk. We also prepared some educational material regarding important tips for pregnant women to ensure food safety, and bigger informative material regarding food-related health risks during pregnancy and after childbirth, and preventive measures to manage them regarding food safety and hygiene when they prepared food. So we think that too little attention is paid to food safety topics in general, and also in prenatal parenting classes specifically. We help to inform pregnant women and also postpartum mothers about food safety issues through trained health professionals, for example, midwives, with credible resources is crucial for the consistency of messages and increasing food safety awareness among vulnerable consumer groups. So I would like to thank you for your attention.
Thank you so much, Dr. Mochka, for the presentation. So any question from the audience side?
And or giving birth in water. So I've been interested in this. I've been a midwife since the late 1970s, and I've worked in different countries, but essentially my core base has been Oxford Hospital, which is a large maternity unit. And I was always curious about exploring ways to optimize maternal physiology in labor. So that triggered my interest as a young midwife in pool use. So just a quick introduction. We know it didn't just happen yesterday. Recorded in 1805, that's happening in France. And in the 60s in Soviet Russia, there was quite a movement as Igor Chopkovsky, a shipbuilder, had some midwives, and they use water and they got permissions to. So water is part of the culture because people go to the banya and babies do baby gymnastic and they swim. They encourage baby swimming. So then it became interesting some people started to be interested in this in the UK, United Kingdom. I would say in the 80s, mid to late 80s, and the government in the UK at the time registered that women and their families were feeling processed like peas in a factory when they were during childbirth. That was becoming very mechanistic and they didn't know their caregivers. And so the Winterton report was very important because it was the first government report to explore from the mother's perspective how the care, her experience basically of care. And then that spawned an expert committee that came up with 3 C's: choice, continuity, and control. And within this, the birth pool was kind of symbolic somehow. So it became recommended that there was an option in maternity hospitals of a birth pool. And then back in 2006, it desperately needs an update. The Royal College of Midwives and the Royal College of Obs and Gynae did a position statement on water birth. So it's just a synopsis of how we've got to where we've got here in the UK. And now every trust, so there's about 158 units in England, for example, and they've all got at least one plumbed-in birth pool. So we were the first to create, to be involved in the development of a birth pool in the NHS, and we were the first place to put it in 1990. So overview and key results of this review and putting it in the context of other work as well and suggested next steps. So just to tell you that I conceptualized 3 systematic reviews, 3 reviews rather, and they've all now been published, and it was the first one was down here. The metasynthesis to examine maternal views and experiences of using a birth pool for labor and or birth, and that was published in 21. And my review that I will focus on in a minute came out in 22, and in 23, at the end, this time last year, just before Christmas, we got this last one, introducing barriers and facilitators, because although everywhere has a birth pool in the UK, and there's lots of freestanding and alongside midwifery units that have, and then pools, women can buy pool in a box, or some community midwife teams offer mothers a pool for home birth. So these reviews are quite important because it gives you, it's one thing looking at the interventions and outcomes, it's very important, but it's equally important to have the maternal experience to learn, and then the system issues, system organizational issues at macro level to understand the best. So here we are on the large review. So this was published, as I said, July 2022, and it still attracts quite a lot of interest because I just, in preparation for this session today, I looked at the alt metrics again for October, for last month. And so we remain in the top 5% of cited reviews. And it's global reach. And I think this is really makes you feel good because it's such a hard slog to create these papers and get them accepted and reviewed and everything, that it's important and helpful to know people are reading them. So why did I push for this, to get a team together to do it? Because I was a reviewer on the Cochrane database of reviews for labouring in water and giving birth, but as you know, they just refer to randomized controlled trials. So I wanted to get beyond that. And whilst the Cochrane reviews are good, people bang on about doing another randomized controlled trial for this, it's not feasible. A, the intervention is unblindable, and B, the maternal choice element has a mandate. So quality observational studies. So I wanted to see what trials had shown in a wider context. And I wanted to move beyond just looking at the interventions and outcomes, but to set them within some context of the birth settings. So these were the two questions of the review. What interventions do they experience? And versus women who don't use water at all. And the outcomes, and for this, it was your classic systematic review, collect and synthesize the evidence. And also we wanted to collect information about birth settings. So the methodology, I'm not going to linger on this slide because the methodology was classic for systematic review. The protocol went up onto Prospero. Eligibility was comparison with land published from 2000. We did another search to see if things had changed after 2010, the messages from the different studies, certainty assessment you see there. And so we followed religiously the classic systematic review methodology. What did we get? 36 studies. So it's a large sample. And you can see here 157,000 plus mother-baby dyads. So 31 of these studies, this is an important note, 31 of these studies, as you can see, over 70,000 participants, they came from an obstetric unit. They reported on obstetric unit births. And then 4 studies, but still a sizable proportion of women, 61,000 plus, were in midwife units, midwifery led. So they can be an area within a hospital, an obstetric unit that is set aside midwife-led care only, or they can be in the community freestanding, again, midwife-led, and home birth. So this is the distribution. So you can see how it broke down. Water birth, 25 studies planned to have had a water birth. Okay, now I'm just showing you a slide here of a table. So we were able to do, if you look at the bold font, you will see the 3 items that we could do a meta-regression on. The studies were too different to enable meta-analysis on more than these. However, in our paper, we provide the forest plots, and there's a leaning towards benefit mostly. So what's important is here that you can see, whilst you can see the differences, they are statistically significantly less likely to have an opioid injection if they labor in water or give birth in water. An epidural, where you might argue that would be impossible in a birth pool, but I have worked in, I visited this place in Frauenfeld in Switzerland, where they did get in with an epidural, believe it or not. Anyway, less likely to have, because you can see these 95% confidence intervals do not cross the line of no effect. And maternal pain perception was specifically gained from 8 studies. And here you see again, less maternal pain perception. So then we get into the bold font, clear evidence that you are less likely to have an episiotomy. And this is interesting. It's not just water births. So let's say you labor in water and you get out before the birth, you're still less likely to end up with an episiotomy, and you're more likely to end up with a spontaneous birth, even if you get out. So this is interesting. We were not expecting to find excessive blood loss to be a big deal, but it seems to be. You can see nearly 64,000 mother-baby diets, 15 studies there, significantly less likely to have an excessive bleed. And this could be in part because, there's a reduction in epidurals, there's a reduction in augmentation as well. And these are factors that can predispose women to excessive bleeding. We saw increased intact perineum, and this is important. Again, within 17 studies reported on this. This is important in the context of increasing anxiety around OSI, obstetric anal sphincter injuries, and awareness of these, and a large initiative initiated in the UK around adopting a hands-on approach, the OSI Care Bundle, but we don't do this in water, and that has been a concern expressed in the UK and beyond, but in fact, you're not more likely. No difference of increased likelihood of OSI with birth pool use. And we didn't see an increase or decrease of cesarean section. That's what that CS is. So I think that's probably in part explained by most studies, 31 remember, of the 36 happened in the obstetric unit, where mothers are more likely to have intervention, even if they use a birth pool. Neonatal. So we went with the international definition, 7 or less at 5 minutes. So, you know, no problem there. No increased likelihood of resuscitation. Transient tachypnea of the newborn, again, it didn't make a difference. Respiratory distress, neonatal death. Increased cord snap likelihood, again, this has been reported in studies happening for water birth. And a lot of ideas have been put forward, like the cord gets waterlogged or whatever, but this is not physiologically the issue. And whilst I can't hand on my heart say what is the issue here, I do think sometimes people are anxious, of course, and they want to bring the whole baby up out of the water, and you're less able to see how long the cord might be in water. So it's really good to be gentle and just focus on gently getting the baby's head out of the water, because that's what stimulates the baby to breathe and inflate its alveoli. So the limitations on this was we a great sample, etc., good analysis. We didn't have reporting for the contextual issues that we wanted. Objective 2, care model was rarely described in the studies. The birth pool description, would you believe it, only 7 of the studies actually described the intervention. The size of it, and we know size matters, we know depth matters, we know women need that person and want that personal space and to be able to have buoyancy to move around freely. We didn't have enough information to make conclusions or anything, or to do meta-analysis on how the baby was monitored in water, hands-on or off. 3rd stage management, whether it was active, mixed, or physiological, and whether the placenta and membranes were born in the water. So we weren't able, you can see table 3 in the paper, to achieve objective 2. And we were only able to do these for intact, appease, and primary PPH. However, you know, there's nothing like being copied as a good compliment. And our review did stimulate a lot of interest in America and continues to. And in fact, it went on CNN News when it was published in that July 22. And a female representative from the American College of Obs and Gynae went online to say they needed to reflect and revisit the concept of birth pools for mothers in America. And lo and behold, at the beginning of this year, the HAOG did their version of a systematic review and meta-analysis of maternal and neonatal outcomes. And this is again open access. And it's very good news, you know, because it reiterates what we found. And again, a large sample of people. So I think this is reassuring. So the key messages are: for healthy women who experience a straightforward pregnancy, reach term, gestation, and have a baby, laboring and or water birth, giving birth in water is perfectly safe. It can reduce intervention in the obstetric unit setting. And that is an important point, because an awful lot, most women across most countries now give birth in that birth setting. And I mentioned the cord avulsion. There has been, I'm just putting this in for interest, in case anyone would like it to engage with it, because again, it's open access. This is a CPD resource for maternity clinicians, be they midwives, student midwives, or obstetricians doing a spontaneous birth. Because a concern has been expressed around estimating blood loss accuracy in a birth pool environment. So we've created a very helpful module, and you do some quizzes, and successful completion results in a certificate. So this was officially launched this June, but it was open access from last December. And a lot of people in different countries, students and different professions engaged in maternity care are using it. So I thought I'd mention that because that's a concern. Next steps. So what do we need to do? We need to contextualize birth pool use. We need to translate these good results such that we can understand practices and places to improve the evidence translation. We need to collaborate to agree on standardized definitions, because doing that large review raised what we knew already, but put it in bright lights that the need for standardized definitions. And we need to collect and share data for all maternal and obstetric characteristics, because across some of those studies, there were women who were induced, had an induction of labor, women in larger bodies, higher BMI, women with hypertension, women with who'd had a previous cesarean section, so of mixed risk. So we need to do this now and share our information, because it's happening, but the data are not being collected specifically for these groups, women of mixed risk, separately. Inform women, we should be informing women about the benefits of water immersion and equity of access to a birth pool. So whilst I've said every hospital in the UK has a birth pool, at least one, we know that in general they're underused. And now that there's telemetry and so on for women of mixed risk, why are they? And we need to undertake an economic analysis of this. So to conclude, it's enjoyed by the childbearing population. It's not going to disappear. It can reduce intervention and adverse outcomes in the hospital setting. Birth pool has the potential to modify a very risk-preoccupied care culture. And I think that's very important, modify behaviors, because some of those studies made this point in their concluding comments and their discussion. It also provides a means for midwives to acquire core intrapartum skills that are transferable to labour and birth on land, and it enhances maternal agency, which is terribly important. The service needs to be wrapped around the woman, not the woman having to wrap herself around structures and a system that's not supporting her at this vital time in her life. Thank you. Any questions?
So thank you, Dr. Ita. So any question from the audience side?
The 2002 World Cup football cup. Here is where I work in the Center of Medical Education and Clinical Investigation, CEMIC, and it was founded in 1958. It is a non-profit organization aimed at the community well-being, and CEMIC is devoted to teaching and research in order to provide a highly qualified medical service. So the theme that I'm going to talk is about the technology, especially used, how we can use it in the delivery room. So one of definition of technology is it is a set of theories and techniques that allow the practical use of scientific knowledge. But when we use the technology, we don't have to forget about the goals at the delivery room. The goal of immediate newborn care is to support the newborn's respiratory and circulatory systems during the transition from preterm to neonatal life, and establishing mother-child contacts as early as possible, and promoting and facilitating adaptation to life outside the womb. Here is where I work, and some photographs about showing the operating room, the delivery room, and where we receive these newborn babies. And if we talk about the preterm infant, the WHO, the World Health Organization, defined preterm as babies born alive before 37 weeks of pregnancy are completed, and there are subcategories of preterm birth based on gestational age. When we talk about extremely preterm babies, they are born before the 28 weeks, very preterm 28 to 32 weeks, and moderate to late preterm 32 to 37 weeks. This population is very unique, and it is highly vulnerable. The preterm infant also has a narrow physiological margin, so interventions must be safe and effective. And in this moment, when the preterm is born, sometimes it's very difficult to manage in the neonatal intensive care unit, but it is more complex to manage at birth due to the infant's rapidly changing physiology. This transition to life after birth is an extremely critical phase, with individuals' risk of death, injury, or lifelong disability. So we must focus in the stabilization of preterm infants in the delivery room, but this must be brief. But a lot of interventions must be made, needed to be performed to stabilize the infant in a time-sensitive manner, taking on account the temperature, ventilation, and the oxygenation. So the technological innovations have improved care of preterm infants in the neonatal intensive care unit, where we can monitor meticulously, and devices are used to provide treatment in a safe and sophisticated manner. And these automated technologies were or not in combination with artificial intelligence, like servo control incubator, algorithm-driven ventilators, automated oxygen titration, predictive monitoring, has decreased the manual work in the NICU and improved care and outcome. But maybe this technology are not well used in the delivery room. So in the delivery room, we must monitor and stabilize the temperature, the patient cardiac and respiratory frequency, and blood saturation. So one of the first things to do at the delivery room is to manage the temperature, the newborn temperature. First of all, we have to to prevent the heat loss, which easily occurs in the exposed and wet infants through convection, conduction, radiation, and evaporation, resulting in a decreased body temperature. We have to take on account that hypothermia after birth is a significant contributor to neonatal morbidity and mortality, and our goal is to keep the newborn body temperature between 36.5 and 37.5 degrees. How we can manage this? Increasing the room temperature using hot towels and compresses, and put the newborn a head cap. And in the case of premature infants, we can use reception bags. So we can put the baby into these bags, specially designed for these premature babies. Also, we can use a Ryan heater with a servo control and with thermal mattresses. The servo control is a thermometer that is connected to the Ryan heater, so it shows everything at every moment the temperature of the baby at the very moment when it is using it. The temperature managed based on continuous thermometer measurements requires constant attention. So the servo control thermoregulation replaces manual temperature management with frequent or continuous measurement. And the servo control usually give us visual or audible cues when rates are exceeded, provides decision support for preventing heat loss, enabling automated regulation via servo control mattresses and radiant warmers. So infants are more exposed in the delivery room than the NICU, so full automation of thermoregulation asks for completely different closed-loop solution, minimizing the effects of the environment on their temperature. So it is one of the things that we can do is to transfer this premature baby from the delivery room to the NICU with this incubator, which has a servo control. So in order that the incubator makes the work, let's say it makes necessary changes to maintain the normal temperature itself. Also, when we receive not only a preterm baby, but also a term baby, is to take into account the tactile stimulation, which is not standardized and sometimes it is forgotten. But neonatal resuscitation guidelines present an algorithm to be followed that includes it and indicate that it is not recommended to perform tactile stimulation for a long time because it would imply a loss of valuable resuscitation time. So the introduction of automated medical vibration stimulation would guarantee to be safe, although vibratory stimulation devices are currently used in some units to reduce apneas, they had not been implemented in the delivery room. Also, sometimes they have to use a continuous positive airway pressure called also CPAP. We have to use it when preterm babies breathe at birth, when the effort is often insufficient to ensure large pulmonary physiological changes. So we have to help the baby with this CPAP, and it is used to support the infant's breathing, considering the physiological changes that need to occur during transition. A dynamic CPAP strategy should be used. CPAP levels with the different transition phases, but it needs a permanent supervision. And which is the role of the CPAP? This is to promote lung aeration and assist lung liquid movement across the distal airway wall into the interstitial tissue. Airway resistance is due to liquid high viscosity moving across the airway epithelium, requiring higher CPAP levels to overcome this. So once the lungs become more aerated and liquid is accumulated in the interstitial tissue, the role of CPAP turns to maintaining lung aeration. But lower CPAP levels are likely sufficient to maintain aeration and support breathing, decreasing the risk for lung overexpansion and/or adverse effect on pulmonary blood flow. And this dynamic CPAP approach is called physiological-based CPAP. That it should ideally start with CPAP levels of 15 centimeters of water, which is stepwise decreased to 8 centimeters of water. And this CPAP promotes lung aeration, breathing effort, and pulmonary blood flow without causing building of the lungs and pneumothorax. It also led to a quicker restoration of heart rate and shorter duration of mass ventilation, likely reflecting lung aeration. And it is difficult to combine standard care with a CPAP protocol that requires contact, evaluation, and changes in the CPAP levels. Here, what we have to think about if technological innovation could help assimilate complex physiological changes and fine-tuning and optimizing the respiratory support. And mathematical modeling with current available physiological data could be used to create algorithms which will allow to develop an automated pressure support system in the delivery room. Sometimes the CPAP is not sufficient, but the baby may need a manual non-invasive positive pressure ventilator that which is provided by a T-piece resuscitator when newborns fail to clear their lung liquid, establishing functional residual capacity and initiating spontaneous breathing. And this positive pressure ventilation, this sufficiency of provided tidal volumes is confirmed by adequate chest rise, auscultation, or by an increase in heart rate. Due to rapidly changing pulmonary physiology and newborn inconsistent respiratory drive at birth, variable tidal volume are administered that might be inadequate or excessive. Large tidal volumes could overstretch the delicate alveoli and airways, causing volutrauma, while small tidal volumes could lead to loss of lung volume or cycling between collapse and recruitment at electrotrauma, thereby injuring the lung. And we have to think about the high percentage of ineffective manual ventilation could be caused by pharyngeal ventilation, as the glottis is closed after birth and only opens when a spontaneous breath is taken. When ventilation is provided to a closed glottis, no air is able to enter into the lungs. Providing inflations which coincides with spontaneous breath would be more effective, but also increases the risk of high tidal volumes and thus the risk of lung and/or cerebral injury. So it is difficult to evaluate the presence and quality of spontaneous breathing at birth, especially during manual ventilation that hampers safe and effective ventilation. So maybe to introduce the technological in the delivery room, it will be beneficial for each delivery room to have a T-piece resuscitator to provide positive pressure ventilation. And when we give supplementary oxygen to the baby, we have to take care about the CO2, about the concentration of oxygen. So oxygen administration is guided by predefined oxygen saturation target ranges, and this must be done manually to treat the fraction of inspired oxygen accordingly to avoid hypoxia and hyperoxia at birth. Hypoxia for more than 5 minutes after birth is associated with an increased risk of mortality and development of intraventricular hemorrhage. And hyperoxia needs also to be avoided as it increases the production of free radicals, inhibits the respiratory center, and could lead to retinopathy. It is critical to adequate control oxygenation during this period as the lung is constantly and rapidly changing. There is also some devices that give autofio, so a closed loop of giving the oxygen that the baby needs. And it's also the international guidelines also recommends the use of a multiparametric monitor in the delivery room for physiological feedback to control the newborn developing. So although the development and adoption of medical technology is revolutionizing medicine and changing paradigms, the delivery room has yet to receive this impact that could reduce human error in the reception of the newborn. The use of technology should not replace observation and newborn constant support during the time of extreme vulnerability, but instead leads and supports caregivers to improve the direct care of the child. The role of neonatal nurses is to act with the best available knowledge without forgetting the participation of parents even during initial stabilization. Regardless of technological advancement, it is vital to maintain families, ties, and connection. The improvement in the quality of care at preterm childbirth will depend on the training of professional teams and the humanization of care, like including parents in everyday care. And this month, we are celebrating the World Prematurity Day, which is in November the 27th. And here are some photographs about some activities that we are making in CEMIC, promoting this day. And well, the WHO, also UNICEF, make 10 rights of the premature baby, and we are celebrating one of them, which is together at every step from hospital to home. Thank you.
So thank you, Dr. Lasala. So any questions regarding this presentation?
Thank you, Sandra. Apparently healthy population to detect a non-obvious diseases and to start treatment before clinical manifestations. It covers the entire population, involves, in this case, the newborns. There must be a circuit for patient follow-up, recalling to repeat the sample, performance confirmatory method in case that is doubtful, and must be easy to make and low cost. So we have the sample collection. In case we have a doubtful result, the patient must be recalled and the sample may be repeated to confirm or discard the diagnosis. And in Argentina, we make some screening for example, the screening for metabolic and endocrine diseases, congenital infections, Chagas, syphilis, HIV, cytomegalovirus, rubiola, hepatitis, herpes. Also, we screen autoacoustic emissions, pre- and post-ductal saturation, Ortolani and Barlow hip test, red reflex, group factor, and Coombs. So we are going to talk about each of them. In the neonatal screening, we look for the congenital adrenal hyperplasia, also congenital hypothyroidism, biotinidase deficiency, cystic fibrosis, galactosemia, and phenylketonuria. This table shows every disease, what happens with the baby if he doesn't have without treatment, and the treatment. In case of congenital hypothyroidism, it can cause without treatment severe and irreversible mental retardation, and the treatment is very easy to provide, is L-thyroxine. In case of phenylketonuria, without treatment, it can cause severe and irreversible mental retardation, and the treatment is phenylalanine-free diet. In case of galactosemia, it can cause liver failure, cataract, mental retardation, premature ovarian failure, and the treatment is also very easy. The use of using soy milk or low-cost lactose diet. In the case of biotinidase deficiency, it can cause blindness, deafness, seizures, mental retardation, and the treatment is giving the baby biotin. In the case of cystic fibrosis, it can cause pancreatic failure, respiratory failure, and the treatment is very specific according to the commitment. In congenital adrenal hyperplasia, it can cause salt loss, crisis, incorrect sex assignment, and the treatment is with hydrocortisone. And it is very important to know when we have to collect these samples. The first sample that we collect in Argentina is between the 40 and 48 hours after birth, especially if they are with the mom in the room, even if the newborn has not received enteral support, and it is repeated, in this case, 48 hours after starting enteral feeding. And if the baby is too small, and it is very preterm, we take him a second sample. Premature babies repeat at 2 weeks of age. Depending on weight, we consider to take a third sample. Before, also, it is very important to take this sample before a blood transfusion. If the newborn receives a transfusion, take the sample prior to it. Then we have to repeat the sample after 7 days. And if the newborn must be transferred, it doesn't matter how hours of birth has this baby. So it is the dispensing center must take the sample even if the newborn is only a few hours old. So what are, as a nurse, what we have to make all this entire process of collecting and supervising the blood sample. It includes using the appropriate paper, Watman 903, and we have to know which patients we have to make the sample. We have to use the correct technique at the right time. We have to register in the nursing medical record and documentation, and we have to send it to the laboratory in appropriate conditions. So the process begins when the confirmation of newborn identity. Also, confirmation of the date of birth to assure that it is in the appropriate period of extraction. And the perform printed on the sample collection card must be filled in clear and legible handwriting. It must include the update data of mother and newborn. Here is one of the examples of the card that we use, where we must complete all the baby's data as last name, date of birth, weight, sex, at what time does this baby was born, gestational age, whether he had breastfeeding or formula feeding or parental nutrition, if he had received a transfusion or exsanguineo transfusion. And on the other side of the card, we also have to put all the mother's data, where she lives, the cell number, and if she has some of these diseases like hypothyroidism, fibrosis cystic, or whatever. And how we take this sample? Well, looking at the newborn's feet, there are two areas that must be chosen to make the punch. We have to preheat the area for at least 3 to 5 minutes with the cloth dumped in warm water or between our hands. Clean the area with alcohol and dry with sterile gauze. It is very important to use alcohol, not yodo. And we have to puncture lateral areas of the heel. We have to discard the first drop, and then we have to complete the filter paper 1 drop per cycle. Only 1 drop, not to fill with a lot of drops every cycle. When we finish to take this the sample, we have to place it on slotted cardboard racks and arrange cards during driving. Never dry the cards by artificial means, microwave, oven, stones, or by sunlight. We have to stack them, rotated alternately with each other so that the blood drops area don't touch one another, don't get in contact. It is important to dry this the card in a horizontal position. We have to let it rest at least to a room temperature for at least 4 hours. And well, it is also very important to have this registration. Where I work, we have a drive where we put all this information, the date of birth, date of the sample was taken, all the data of the newborn and the mother, where she lives, who took who made the sample collection. And if and when we finish, we envelope and send to the processing laboratory as soon as possible. And this method is very useful because it can be sent by mail, courier system, or ambulance to the laboratory which will process the sample. This is how they process. I went to the laboratory to see how this was processed. Those are the circles with blood, with the blood collection, and they punch one of them and put it with some, well, I think liquids are laboratory things, and it is very handmade, handcraft. So when the sample is processed, we have the results. The laboratory must make sure that the family and the pediatrician get results as soon as possible. And this must be documented in the medical record. But in case we have doubtful results, it is very important that the laboratory will immediately and reliably communicate parents, baby guardian, hospital, or referring professional the obligation to carry out a diagnostic confirmation analysis and will grant the responding report. If we have a normal test, okay, it is normal. But it is the doubtful results, the newborn must be resuscitated to perform a confirmatory sample. If it is presumed pathological result, we have to, the laboratory must do the confirmation and the hospital must be follow this baby and treat him. In case that it is doubtful, the child must be located as soon as possible so that samples can be taken for confirmatory analysis and the newborn be controlled by a specialist. In case of inadequate or doubtful sample, the laboratory will request a new sample within 24 hours of the result of the first analysis being known, and the doubtful or positive analysis and its diagnostic confirmation will be recorded in the patient's medical record. When I told you also that we made some another screening. No, for example, we do this congenital, looking for the congenital infections. Microorganisms that cross placenta can cause infections transmitted from mother to the newborn. And it is taken by the blood test of the cord. And I told you that we make Chagas. Chagas is an endemic infection caused by the parasite in the Trypanosoma cruzi, transmitted with the bite of the kissing bug called Vinchuca. So we look forward for these congenital infections in every child in Argentina. And the autoacoustic emissions are low intensity sounds produced in the normal cochlea by its own activity. It is measured by a sensitive microphone that picks up echoes that stimulate cochlea, and if it's functioning normally. It detects abnormality of the middle and ear. We also perform this screening looking for congenital birth defects, birth defects. So we put we make a preductal saturation is controlled in the right hand and postductal saturation in the left foot at 24 hours of life. If the result is less than 25% or the difference between the pre and post-ductal saturation is more than 3%, it is considered a newborn at risk of congenital heart disease. And we have to make him 3 controls during the day. And if the results are maintained, a Doppler ultrasound must be performed on the same day to detect ductus-dependent congenital formations. This year, we had a tetralogy of a lot who was diagnosed by this screening. And when the doctors make the physical examination, they also make this Ortolani and Barlow hip test, exploring for a congenital hip dislocation. ortolani and barrow movers must be done in the early neonatal period. It is recommended that in the event of a positive clinical mover, the child must be referred to an orthopedist. Hips examination, abduction, and asymmetries in all subsequent health checkups up to 1 year of age. And in the physical examination, we'll also make this red reflex. It's when we put it has a light transmission control in the transparent parts of the eye, cornea, aqueous humor, crystalline, and vitreous humor. The light must be reflected from the back of the eye, and any abnormality that prevents the passage of light will indicate an abnormality in the newborn eyes, like congenital cataracts, glaucoma, or retinal abnormalities. And another screening that we make is growth factor and Coombs. It is very easy because it is made from cord blood when a baby is born. And it is important to know the maternal and newborn group and factor to determine the possibility of an AVO and ARIT incompatibility. So, as nurses, we have to ensure that all newborns, healthy or sick, undergo routine examinations, collect data from the newborn, the mother, and family in order to carry out a proper baby follow-up, explain clearly to parents the importance of all exams performed, and our work is not limited only to carrying out the studies described above. We are responsible for ensuring that all newborns have the same opportunities. This photo represents some of the newborn in CEMIC, and the girl who is playing field hockey on the right side is my daughter. When she was born, she was diagnosed of galactosemia, and thanks for this screening, she is 18 years old now, and she's having a normal life. Thank you.
Thank you, Dr. Lasalar, for the presentation and explaining in detail. I hope the audience have benefited from your views and research. So any question from the audience side?
Tata, India. So, motherhood is a precious gift. The wonderful feeling of being pregnant, the unworldly changes that occur inside the body of a woman, and the pain, confusions through which a pregnant woman has to go through, can't be defined in words. Every woman can experience sudden and unexpected complications during pregnancy, childbirth, and just after delivery. Among them, few complications may turn into maternal near miss or maternal mortality. So I would like to clear the term maternal mortality and maternal near miss first. So what is maternal near miss? According to World Health Organization, that is WHO, maternal near miss refers to a woman who nearly died but survived from a complications that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy. And what is maternal mortality? It's also according to WHO. Maternal mortality refers to the annual number of female deaths from any cause related to that pregnancy during the time of pregnancy, childbirth, or within 42 days of the termination of pregnancy. But it excludes accidental or incidental cause. So the basic difference between maternal near miss and maternal mortality is that here in maternal near miss, women survived. But in case of maternal mortality, here women died. Come to the next topic, that is the data of maternal mortality worldwide. We can see, as per the data of World Health Organizations, in every 2 minutes, there is one maternal death in the year 2020. And also we can see that between 2000 and 2020, that is within 20 years, there is a huge drop in maternal mortality ratio, that is 34% worldwide. But still, there is 287,000 women died during and following pregnancy and childbirth globally. And the global maternal mortality ratio in 2020 was 223 per 1 lakh live births. And it's also vary according to high income country and in low income country. The maternal mortality ratio in low income country is almost double, that is 430 per 1 lakh live births. But in case of high income country, it only 13 per 1 lakh live births. So we can see there is a huge variation between that high income country and low income country maternal mortality ratio. And India is also a low income country. So now we will see the maternal mortality data in India. As per report of Special Bulletin on Maternal Mortality in India 2022, in the year 2014 to 16, here we can see in the bar diagram, maternal mortality was above 100, that is 130 per 1 lakh live births. But in the year 2018 to 20, it comes to below 100, that is 97 per 1 lakh live births. And according to World Health Organization, the Sustainable Development Goal, that is SDG, target 3.1 is to reduce the global maternal mortality ratio to less than 70 per 1 lakh live births by the year 2030. So to achieve this SDG target, we have to focus more on maternal near-miss study. As because maternal near-miss study women survived, so they can act as a source of data by giving feedback regarding their critical life situations during the time of pregnancy, childbirth, or within 42 days of the termination of the pregnancy. That maternal near-miss study, if we see, already started long year backs. Here we can see in the year 2007, already one study done in maternal near-miss in Brazil. They identified total 124 maternal near-miss cases, and among them 80% were admitted in intensive care unit. And they identified the main cause of that maternal near-miss as severe preeclampsia, that is 36%, followed by severe obstetric hemorrhage, 10%. Similarly, very recently also one study done in maternal near-miss in Ethiopia, that is in 2024. They also got similar result like the previous study. There's also main cause of maternal near-miss is severe preeclampsia followed by obstetric hemorrhage. In case of India, there's also few studies done in maternal near-miss. We can see here that is the Haryana, northern part of India. They also done that maternal near-miss over 1 year. They identified total 469 maternal near-miss cases. But they got that main cause of that maternal near-miss is obstetric hemorrhage followed by severe preeclampsia. That is, they identified obstetric hemorrhage as 67% and that severe preeclampsia 36%. Another study also done in the southern part of India, that is in Karnataka. They also got the similar results like that above study. There's also main cause of maternal near-miss is obstetric hemorrhage followed by severe PPH, that is postpartum severe preeclampsia. They identified the prevalence of maternal near-miss as 2.56% over the 7-year study period. As we know, India is a larger country and socioeconomic status vary from region to region, and also the health status of the individual vary as per the socioeconomic status. So I have done my study in the eastern part of the India, that is in Kolkata city of state West Bengal. So here the objectives of my study is to assess the occurrence of maternal near-miss among women admitted in maternity unit of selected hospitals. And second objective is to identify the factors of maternal near-miss among women admitted in maternity unit of selected hospitals. These are the primary objectives, but the secondary objectives is to find out the association between determining factors and selected sample characteristics of maternal near-miss women. Next, come to the point, research methodology. We have adopted survey approach and non-experimental descriptive design we used during our study. And the sample were the women who have admitted in maternal unit of selected hospitals during pregnancy, labor, or within 42 days of termination of the pregnancy, with WHO selected any one of the maternal neonatal criteria, specifically severe complications or critical interventions or organic dysfunctions. Among the severe broad headings, anyone if criteria fulfill the mother during the time of admission to that selected hospitals, or they can develop that criteria during their hospitalizations, and it should be diagnosed by the physician on women's treatment chart. So that should be taken as maternal neonatal cases. Here settings is Arjikar Medical College and Hospital and NRS Medical College Hospital. Both are government tertiary level hospital in Kolkata. Then the sample size, we have identified total 100 sample as a maternal neonatal case by using the non-probability purposive sampling technique. And the sample criteria we used included the mothers who fulfilled the WHO selected maternal neonatal criteria during their admissions or during their hospitalization at the time, and developed any one of the criteria of WHO selected maternal neonatal criteria during the time of pregnancy, childbirth, or within 42 days of the termination of the pregnancy. Or we exclude maternal neonatal related to any accidental or incidental cause. We have excluded them. The research variables are, first one is the specific sample characteristics. That means the background information of the participants, that is age, education, occupation, monthly family income, marital age. That next is the occurrence of maternal neonatal. Here occurrence refers to number of maternal neonatal cases we have identified as per total admission of the obstetric, total admission of the women during the obstetric units during the study period. So we have taken them as occurrence. And factors of maternal neonatal refers to reproductive and obstetrical factors and maternal delay factors for the neonatal case. In data collection tool and technique, we used semi-structured interview schedule for collecting the data related to specific sample characteristics and factors of maternal neonatal by interviewing technique, and we used observational checklist by doing record analysis from the woman's case note or a logbook for the occurrence of the maternal neonatal. Then ethical consideration obtained from the Clinical Research Ethics Committee, Arjikar Medical College Hospital, Kolkata. Full validation done by the subject experts and reliability tested by speed-up and iterator method. Data analysis done by descriptive and inferential statistics. Next, come to the analysis part. So first is the frequency percentage distribution of the sample characteristics. Sample characteristics means background information of the participants. So here we got total 100 maternal neonatal cases during the study period. Here we can see among the participants, maximum of the women, that is 42%, are within the age group of 16 to 22 years. And they are more than half of the women, that is 53%, from rural habitat. And their educations, most of the women, that is 38%, education up to secondary level only. In occupations, they are almost all of the women are homemaker. And family income, they are 40% of the women from the below socioeconomic status, that is their income within 5,000 to 10,000, and their marital age 51% within 18 to 22 years. So from this we can summarize that the lower socioeconomic status and less educations and rural habitat may be responsible for occurrence of that maternal neonatal in regards to specific sample characteristics. Then occurrence of the maternal neonatal. Here we have identified total 100 maternal neonatal cases. Among them, that is the WHO neonatal criteria, severe complications. Among the severe complications, we have identified the main cause of maternal neonatal as eclampsia, that is 27%, followed by severe preeclampsia 19%, and last is obstetric hemorrhage 6%, and then it's sepsis and rupture of uterus. And here that is the 46% none. That means it multiple response stable. Here multiple response stables means here one participant or women can develop one or more than one complications at a time. show the total sum of that frequencies may exceed the total sample number. So that's why it's multiple response table. That 46% cases have not developed any of the criteria under severe complications. And then under critical interventions, most of the women, that is 54%, admitted in intensive care unit. There also 41% women have not developed any of the criteria under critical intervention as it was multiple response table. And another criteria is that organic dysfunctions. Here the occurrence of organic dysfunction is very minimal. Only about 2% cases develop few complications like dialysis for acute renal failure, severe hypoxemia, and severe tachypnea or severe bradypnea. So we can tell that eclampsia and severe preeclampsia, that is the hypertensive disorder of pregnancy, are the main cause of maternal neonates, followed by obstetric hemorrhage. And most of the women are admitted in intensive care unit. Then total 1,669 women admitted in selected maternity unit during the study period. Among them, 1,644 women delivered at the hospital. And the remaining women admitted as postnatal case or remain as antepartum case. And among 644 women, 1,600 total live births and 100 maternal neonates case, and the one maternal death recorded. And the maternal neonates ratio calculated as 62.5 per 1,000 live births. And the maternal neonates rate is 59.91 per 1,000 obstetric admissions. So the ratio of maternal death to maternal neonates, that is 1:100. Next, come to the point, factors of maternal neonates. So here mainly the reproductive obstetrical factors and maternal delay factors. Among the reproductive obstetrical factors, we can see that is the age at first conception greater than 18 years have more than half of the women, that is 62%, have age of first conception greater than 18 years. And most of the women are multigravida, that is 65%, and multipara, that is 54%. Remaining women are as primigravida or primipara. And they have history of gestational diabetes in 31% women, and 35% have history of abortions. And that 20% women have less antenatal checkup, less than 3 times in their entire antenatal period. Also 5% cases does not register or they remain undiagnosed and untreated during their entire antenatal period. And more than half of the women suffered from that prolonged labor, that is 65% cases. And more than 3/4 of the women, that is 79%, are the referral case from that primary hospitals, and the maximum of the women, that is 78%, undergo cesarean sections. Among the delay, the type 1 delay is the 53% and type 2 delay is 67%. Here type 1 delay means the time taken to decide to seek care greater than 3 hours. It may be due to their unawareness or lack of knowledge regarding the critical situations, or maybe due to lack of decision-making ability. And type 2 delay means the time taken to reach to health facility greater than 1 hour. It may be due to long distance or lack of transport facility, or maybe the financial imbalance. So here we can see that the use of public transport is 65% of the women during their critical life situations also. So that may be caused the type 2 delay. So that type 1 and type 2 delay, among the delays most responsible for occurring of that maternal neonates, and among the reproductive obstetrical factors, that is the multigravida, multipara, history of gestational diabetes, abortion, less ANC checkup, prolonged labor, referral cases are mostly responsible for that occurrence of maternal neonates. Next, the analysis, that is the find out the association between the determining factors and selected sample characteristics. That is was my secondary objectives. So before that association, we have to know about the basic terms related to that statistical. Here median means the middle value of that data set. It may vary according to odd or even data set. Chi-square test means it used to examine the relationship between the categorical variables. It is calculated as summation O minus U square by E, That is, O means observed frequency, and E is expected frequency. And degree of freedom calculated as row minus 1 multiplied by columns minus 1. And significance levels means how much the researcher rejecting the null hypothesis. In our health science, we generally consider it as 0.05 or 0.01, that is 5% or 1% level of significance. So the association between reproductive obstetrical factor score with maternal educations and marital age, that is the specific sample characteristics. If that calculated chi-square value is greater than the table value of chi-square at specific degree of freedom, then we can tell that there is a significant association present. So here in our study also, you can see the maternal education score calculated chi-square value is 14.39, which is greater than the table value, that is 11.34, a degree of freedom 3 and significance level P less than 0.01. So it's significant. Similarly, in marital age also, there is calculated chi-square value 11.85, which is greater than the table value 9.21 at degree of freedom 2. So we can tell that the maternal education and marital age are responsible for occurrence of that reproductive and obstetrical factors to cause the maternal neonates, as because there are significant association present between that factors and maternal education and marital age, that is the sample characteristics. And remaining sample characteristics have not identified any association with that reproductive and obstetrical factor score. Next, come to the point maternal delay factor score. Association between maternal delay factor score with residence and maternal education. N equal to 100, that is the sample size. So here also we can see the residence calculated chi-square value and maternal education chi-square value calculated, both are greater than table value of the residence and maternal education at degree of freedom respective and level of significance less than 0.01. And similarly, another sample characteristics, that is monthly family income and marital age. It's also significant association with that maternal delay factor score. So we can tell that low socioeconomic status and less education and rural habitat may be the responsible for that maternal delay factor that ultimately cause that maternal neonates. Next, so conclusions. The eclampsia and severe preeclampsia, that is the hypertensive disorder of pregnancy, are the main cause of neonates, followed by severe postpartum hemorrhage. And to improve that or prevent that maternal neonates case, we have to improve the antenatal care and creating awareness campaigns or 100% institutional delivery, and to improve the transportation facility along with skilled healthcare provider is essential to reduce that maternal risks and prevent delay. Gathering feedback from participants helps to improve maternal healthcare quality, supporting the achievement of SDG target. That is, always we will consider maternal neonates as a pre-lesson and opportunity to improve the quality of obstetric care that will ultimately help us to reach our Sustainable Development Goal target 3.1, that is to achieve the maternal mortality rate less than 70 by the year 2030. Okay, thank you. Anyone have any questions?
Thank you, Dr. Dipti, for the presentation. So any questions from the audience side?
Creating multi-collaborative framework in achieving strategic objectives in King Faisal Specialist Hospital Research Center in Riyadh, Saudi Arabia. Okay, let's start with the abstract. The Department of Medicine plays a pivotal role in providing support in pursuit to improve operational efficiency and enable provide access to those who needs the service as one of the strategic objectives. It directed to the priorities and efforts to be aligned with the hospital strategic objectives towards optimizing key performance indicators such as decreased average and length of stay, discharging patient midday, and facilitating patients transfer to other healthcare and external facilities according to the allowable time frame of patients transfer, hence will create a pathway towards patients' experience to their families and patients as well. Forthwith, achieving efficient, effective care and treatment and provide optimal service. Finally, and it will take an effect on the major fundamentals of structure of medicine department and their patients coverage. The objectives of
Miss Maria,
sorry,
I'm so sorry. Your slide is not moving.
as it's moving for me. I don't know what's going on.
It's not visible for us. Still, it is in the first slide.
How come it's moving on my slide? I think.
Can you click on? Okay, reshare it.
Is it okay now?
No, it is not visible.
I think I'm having technical difficulties. Can you see now the abstract, the presentation?
No.
I think I'm having technical. Let me.
Okay, so can I share your presentation on your behalf?
Just a minute. Sure, just a minute. Let me. How can I get out from here? How can I go out from here?
I just give stop sharing.
Okay. Cannot even see it. So sad. It's not. I cannot even see it.
Can you see the share option?
I cannot see anything at all.
Okay, so can I try sharing your presentation?
Okay. Sure. How can I get out from here? I have to finish.
Is the screen visible?
Okay, just a minute. Let me get out from here. All right. Yeah, it's visible now. Sorry for that. It's a technical issue. Okay. I was saying earlier, okay, I was on my second slide. All right. So to give a brief abstract regarding about it, we're trying to show what has been projects regarding about revisionizing collaborative framework within the medicine department in King Faisal Specialist Hospital in Riyadh, together with like a framework or a pathway involving the patients as well as a collaborative team within the medical department. And second slide. Okay, the objectives of my presentations are the following: is our patient care measure and specific clinical intervention in license with the length of stay, streaming the frequent diseases under medicine, internal medicine, being admitted in emergency department to have a clear, appropriate goals of care by the medical teams to foster reliability and to provide a structured approach enhancing patient outcomes and to have enhancement in efficiency and roadmap of referrals for outside facilities, and lastly, to give a pathway and flow of patients being admitted and having the discharge plan initiated. Next slide, please. Okay. All right. To give you a brief preview of Department of Medicine, Department of Medicine is instrumental in providing high quality of medical care and as well as advancing field through research and education with the comprehension services and patient-centered approach to make it more cornerstone with the operations of the hospital organization. And I believe this department has been seeing a lot of patients, which is like 1,500 patients per annum. And we're seeing patients almost like 30 to 50 patients per day, clinic-wise and admission-wise. Next slide, please. Okay, to give you a brief context, we have 7 services under medical service. We have the internal medicine, gastroenterology, pulmonary, nephrology, rheumatology, endocrine, and infectious disease. Next slide. Okay, pathway, we're going to be talking about the ATS, which stands for Admission Tracking Shell, bed board, bed capacity management. We're talking about patient flow on the Department of Emergency Room and inpatient area. We're going to be talking about power chart, in which we're going to be showing you where we're going to be documenting and we place our orders, estimated length of stay, admission assessment, discharge checklist, and resources for discharge plan. First on the list, we're talking about admission tracking shell. This tracking shell will show you how many patients are expected to be admitted in each specific unit or specialty. So this will be a liaison with us as clinical care coordinator, because one of our core responsibility is to identify these patients, where they belong, and how they're going to be admitted to the inpatient area. Next slide. Okay, the bed board will be your resource to identify how many patients are being admitted in each unit, according to which is whether or not they're going to be in cardiology, whether or not they're going to be in internal medicine, and the capacity of each unit, whether or not they have a vacancy or those kinds of beds are being occupied or like for admitted for another services. Next slide. Okay, the bed capacity management will give you details of which kinds of patients are for discharge, okay, and where they're going to be admitted to. This is a very important tool for us to identify how are we going to help or create, break the barriers for discharges regarding about these patients, especially we are trying to meet up like the midday discharges for our own patients. Okay, this is the most important tool, the patient flow Department of Emergency Inpatient Unit, because this will align us, tell us which are those things that needs to be given importance to. Example, like radiology. So we need to identify those patients needs to be given importance so that we can communicate and collaborate with the given specialties or procedures that needs to be done in alignment with those patients and diagnostics tests to be done accordingly in a timely manner. As I mentioned earlier, power chart is, we call it ISIS. This is where we can see those orders and we can see how is the patients coming from when they are going to be admitted in patient unit. So particularly, we can see all those like dietary, radiology requests, procedures, requests, communications, all this stuff, you can see it on the power chart. And this is where the nurses and us coordinators are being documenting are all kinds for the patient. And this is highly confidential. And another thing is that we also need to know the estimated length of stay of our patients when they are being admitted in inpatient unit. So this will give us like, how are we going to establish our plan in order to attain the estimated length of stay? Are we coming too near to that, or are we going above that? So these are the things as my role to do collaborative and identify those kinds of barriers, as I said earlier, in order to meet, the needs of the patients and also the needs of the medical team in order to attain what we are trying to achieve regarding the length of stay. Okay, this admission assessment tool is being done by the primary nurses or the nurses who are assigned in inpatient area. So when they admit a patient coming for emergency or like an elective or coming from the clinic, this is a prerequisite thing to achieve in order to know what is the status of the patients when they receive the patient from other areas. And discharge checklist is a mandatory thing when we are discharging patient from the inpatient area. So we need to know, how are we discharging the patient? Are we discharging patient with the things that they really needed, or we're discharging the patient that they really needed before coming into the hospital? Okay, since we're talking about discharge, so these are the resources for discharge process that we usually use in our organization. So we also have the home discharge when the patient is going to be going home. And we refer also patient to home health care where they're being followed up at home by our distinct team, whether or not it's for IV antibiotic, hydration, or being checked for wound care. We also have long-term facility wherein patients are being transferred for nursing care. Okay, short-term facility for those kinds of patients, only for staying for for short-term, like 5 to 7 days, doesn't need an active treatment from King Faisal Specialist Hospital. And also we have Ministry of Health, in where we are referring this patient back to their own referring hospital and different, provinces in Riyadh or whatever it is. And also we're addressing alternative level of care, this kind of things like involving difficulty in discharging patients. We have a team that will address this issue and escalation of action. So we're part of that. And as much as possible, we don't want to resolve this kind of things with our patients. Okay, to outline, we have our projects for 2024. We had an initial meeting with the multidisciplinary team with internal medicine with the focus area. We also highlighted issues and concerns from the MDR meeting, especially with the medicine department, because medicine department is a very complex area. We created an action plan for 6 months. We showed also statistics, discharges from 2022, 2023, and as well as first and second quarter of 2024. Preceding the length of stay, we also have power plans care set that we piloted in medical department, and also the projects initiated by the inpatient units. Moving forward, I'm trying to show you the minutes of the meeting that we had. So we had focused on the length of stay. We focused on the expected date of discharge we're trying to have issues with, and also issues regarding about procedures and requests. There was a slight delay, and this was also addressed within the meeting that we had. And also, we also had issues regarding about a lot of issues with the medical team that they're not attending to their patients and sort of. And also from the nursing side, they're also addressing barriers for discharge regarding about the pharmacy as well. So these are also within the minutes of the meeting. Okay, to give you a brief preview with that action plan for 6 months, I'm gonna like name a few of them, like the most important ones, like the daily review of patient population, status per unit and medical service, identifying pending diagnostic tests, which I mentioned earlier, or procedures to be expedited in order for the diagnosis and findings, and the review of patients for admission by the medical team if needed to be admitted in inpatient units, escalation process, tracking patient accordingly, referral of difficult discharges accordingly, ongoing orientation of new coming residents to an inpatient unit, which is a by factor needed in order to know what is their responsibility, how they're going to assess patients, and how they're going to discharge patients. And when patients are being admitted in inpatient area, what is the flow for that kind of patient? And then the multidisciplinary meeting, which is essential. And we also increased the number of staffing with 2 respiratory therapists, 1 ecotech, we don't have that before. And then peak days that we increase the number of pharmacists due to the number of discharges that we're meeting every single day. And the availability of vacant beds for borrowed beds for another services. Okay, and then we are now in the process of reviewing power plans for common diseases under the Department of Medicine. Next slide. Okay, this is one of my favorites. We had implemented the power plan, the care sets, initiated the power of medicine department as also a care coordinator. The one of the primary aims for this project are the following: accessible to the medical team who is admitting patients such as these illnesses, diseases as the primary reason for admission from emergency. And this will ease the manual handling the most frequent diagnostic tests being made by the medical team at the internal medicine, as well as to focus on having the length of stay as an expected timeline. Lastly, to improve and define medical assessment, evaluation, and fundamental framework with clinical recommendation adhered. So this is the internal medicine admission care set. So you can see we have the AKI. I mean, some of you are within the medical field. We have CKD, sepsis care set, anemia care set, stroke outside the window care set, and miscellaneous care set. So this is a project that's been, we started since January. Now we are now using it for the past 1 month. And it's been effective because we've been monitoring the length of stay of our patients. Okay, let's go with the statistics. And the year 2022, you can see they were trying to meet our target discharge, target ones for that matter. So we were trying like 176, which is like 88 to 90% target margin for our discharges for the East Wing side. East Wing is the medical side of King Faisal Specialist Hospital. So far on the statistics side for 2022, we're meeting, like, as I said, 88 to 90% of benchmark. Next slide. In 2023, basically it's like we meeting at 88 to 89% because of like exceeding due to the difficulty of patients and the patients, medical conditions. So somewhat we're trying to meet that target discharge and length of stay of the patients. Okay, the next one would be the first and second quarter of 2024. Apparently, we were able to meet our target, for succeeding. We were able to discharge a lot of patients with the help of other services. And we also, with my colleague as well, because we're 2 clinical coordinators. So the benchmark, we were able to meet like 90 to 92% of the length of stay, and patients are being discharged accordingly. And the projects in process in the inpatient unit, we have, as I said, the reducing average length of stay for stroke outside the window, because this kind of cases, they're only staying in the inpatient area for at least 5 days, okay? Discharge checklist, which is initiated by one of the inpatient department to create the click system to identify the needs of the patient at the time of admission, leading towards discharge planning through online. And lastly, the integration of transfer process to incoming residents to current medical teams. So as a clinical coordinator, one of my key roles is to give education so that they know what's the flow and the transition of patients when there's no need for active treatment for the patients in the King Faisal Specialist Hospital, focusing on medical department. And these are my resources. Thank you so much. And that is my contact details. Any questions from your side, from the audience?
All right. Thank you so much, Ms. Maria. So,
Thank you so much.
is there
Sorry for
any?
the technical issue earlier.
It's not
I
a
believe
problem.
it's like, yeah.
Is there any query from the audience side?
For over 3 decades, specializing in reproductive mental health and doing a lot of work and presentations and writing on pregnancy and postpartum depression. So this is a summary of some of my activities. It's a pretty long amount of work that I've done in the last 33 years, but just want to point out a few things. I'm also on the Advisory Council for Postpartum Support International. And at the end of my presentation, I'll present some contact information, including the website for Postpartum Support International, so people can get more information. So to start, I was doing clinical work, but I began to do advocacy work in 2017. And that began where I testified on a bill that was being heard in the Illinois House Subcommittee on postpartum psychosis and postpartum depression related to criminal cases. And the bill passed that day, went on to the legislature, and Attorney Barry Lewis joined forces with me, and we shepherded that law through the Illinois legislature. It became the first law in the United States. It still is. Right now, it's still the only postpartum psychosis criminal law in the United States. And I've been working to get other states to introduce and pass similar legislation in Massachusetts, in Colorado, in California, and other states. And so I'm going to be talking about that. What's also amazing about the law is that it was first written, that legislation was written by two women inmates who had life sentences in Illinois with no parole, and they wrote this legislation from prison. One had postpartum psychosis, the other did not. So due to limited time, I'm going to jump right in. There are a couple key take-home facts that, if nothing else, I'd like you to take these in, and that is postpartum psychosis is one of the most severe and misunderstood maternal mental illnesses. And unfortunately, if it's not recognized and treated early, it can lead to tragic outcomes. Also, second fact is that there's a need to promote perinatal or pregnancy and postpartum laws in the United States and abroad to provide treatment rather than incarceration when criminal culpability is linked to and a direct result of maternal mental illness. So first I'm going to talk about a little bit about perinatal mental illness. Obviously, this is a time when women go through tremendous number of adjustments. And so with all these changes and sleep deprivation, sometimes breastfeeding challenges, and limited time for self-care, it's sort of it can be a perfect storm and a time when certainly a large number of women suffer from maternal mental illness. And basically, there's a continuum of maternal mental illnesses, all the way from perinatal depression and anxiety disorders, all the way to the most severe postpartum psychosis. And perinatal mood and anxiety disorders can appear anytime, couple facts, during pregnancy and during the first 12 months postpartum. It affects 1 to 5 women and 1 to 10 men. It can affect people of every age, race, ethnicity, income, and culture. It's the most frequent complication of childbirth and the most frequent cause of pregnancy-related deaths in the United States. So we often call it PMAD, or perinatal mood and anxiety disorders is what that stands for. And just so you know, it can include symptoms of depression, anxiety, panic disorder, obsessive compulsive disorder, and certainly become, it can also be the most severe with postpartum psychosis. And that's what the rest of my presentation will be about. But I'd like to, just point out that for about 800,000 women in the US each year, they can experience some sort of a perinatal mental illness. And that's due to hormonal, biological factors and vulnerability, genetic vulnerability, societal expectations, and a host of psychosocial stressors. So a few more general facts, and then I'll move into postpartum psychosis. So worldwide, we know women are more vulnerable to mental illness surrounding both pregnancy and postpartum. It's really a myth that women are, do not experience these things during pregnancy. The World Health Organization reports that 13% of women experience depression within a year of delivery. So the prevalence of perinatal mood and anxiety disorders is 10 to 20% of childbearing women. Postpartum psychosis affects, much less women, but it's certainly a large enough number that it's very significant. And that's 1 to 2 per 1,000 births. And that comes to about 4,000 women approximately in the US each year. It's estimated that of those women with postpartum psychosis, 4 to 5% are at risk for suicide, and 1 to 4% are at risk for infanticide, neonaticide, or filicide, which means, those are, we want to keep our children safe. And we don't want mothers to suffer. So we want to intervene as quickly as possible to prevent these kinds of terrible outcomes and tragedies. So many of these tragedies could be prevented with both perinatal mood and anxiety disorders, which is very treatable, and postpartum psychosis, which also responds well to treatment. But what's needed is awareness, screening, and prompt treatment is key. It's really especially with postpartum psychosis, this is a crisis situation. And these women need to be hospitalized for their own safety and protection of themselves as well as their children and families. So moving on, we know that postpartum psychosis is a unique and a serious mental health challenge. Again, it's the most severe form of postpartum mental illness. And here are some of the symptoms. Basically, these women are impaired in their judgment and their reality testing. They can have hallucinations, delusional beliefs, and a whole host of other symptoms. Sometimes they're not sleeping with tons of energy, which is, very unusual. After you have a baby, women are usually just exhausted and not sleeping well. But these women sometimes have mania and have, haven't slept in days or longer, and really are very confused, and it can alternate between depression and euphoria. It's a complete shift from previous normal functioning. Oftentimes there can be paranoid and delusional beliefs about the baby, some bizarre beliefs, things like the baby is Satan, or the baby could is God, or the baby, something like that, all kinds of bizarre beliefs. And so again, they're at risk of suicidal and homicidal behavior and ideation. What's also needs to be pointed out is what's unusual about this type of psychosis is it can wax and wane. That is, they can seem perfectly like themselves at various points, and then other times they might be talking to someone who isn't there or seeing things that aren't there. So, it really needs to be, people need to be screened and aware of this. A couple more facts. We know that postpartum psychosis has been linked to infanticide and filicide cases throughout the world. We also know that research cites that a woman is 23 times more likely to experience psychosis in the month following childbirth than at any other time of their life. Half of these women have no history of mental illness, so it basically blindsides them and their family. They're not prepared for this, and they're a victim of this illness too. That's certainly not something they want. So to prevent tragic outcomes, these mothers with postpartum psychosis or even severe depression with psychotic features require crisis intervention, immediate hospitalization, and psychiatric treatment. Oftentimes, medication is the first line of treatment for these women because they're not experiencing reality. So it's very hard to do psychotherapy until they're stable. Moving on and getting back to the law. So the law that was passed in Illinois, and again, the first law in the US, allows women who are currently incarcerated to file for a resentencing hearing and to allow consideration of postpartum mental illness in their case if it hadn't been considered before. And it's this applies both in the past, present cases, and future cases. So when women are charged currently, hopefully not, but when these things happen currently, they can benefit from this law. And this law was really groundbreaking. It amended the Code of Corrections to consider postpartum depression and psychosis as mitigating factors in sentencing and in post-conviction hearings when women commit crimes because they were suffering from these illnesses. So postpartum criminal laws in the US and abroad are essential when criminal culpability is linked to maternal mental illness. Currently in the US, the law is very harsh, extremely harsh. And the majority of these women who commit these crimes spend years or sometimes their whole lifetime in prison for a crime that was related to childbirth and mental illness, and that they really did not have control of their mental health at this point. There's been a fundamental failure in our judicial system in the US that doesn't accept what we now know through medical science about perinatal mental illness. This isn't true in all countries. This isn't true in some other countries where there is acceptance and there's mitigation in the law for women who have maternal mental illness. These are some of the other countries. There's about 37 countries now that recognize postpartum illnesses as distinct and have these specific laws, again, beginning as early as 1938 in the United Kingdom. So, yeah, so we've got some work to do to get these laws passed in the United States and in other countries so that women get treatment rather than spend a lifetime in prison. So there is the British Infanticide Act, and I'd like to leave you with a couple of facts that, basically there is a need for a lot more research into postpartum psychosis. It's also been researched a lot less than postpartum depression. And there's been an overrepresentation in the of women of color that have been incarcerated in the US. I'm not sure about in other countries, about that fact. But there's been a real lack of research about the connection for women of color with postpartum psychosis. And these research questions haven't been adequately pursued and need to be. And we also need to control for socioeconomic status and other factors, different types of people of color, and not clumping them all together. So a few other things, and I will finish up. So there is a need to enact postpartum laws in the US as well as abroad, and to include postpartum psychosis in the DSM, our diagnostic manual of all sorts of mental illness and mental health codes for better outcomes when these women go to trial and there's clemency hearings. So it's essential to prioritize awareness and prevention of postpartum mental illness to save the lives of women and babies, and to help families that are devastated when these things happen. We must enact comprehensive postpartum laws in every state to address screening and treatment, as well as to consider mental health as a mitigating factor when unrecognized and untreated mental illness leads to tragedy and involvement with the criminal justice system. The time is now to enact these laws and to enact judicial changes in the U.S. and abroad. So as promised, I'm going to, here's some of my references, a book that I've written with attorney Barry Lewis, which is advocating for women with postpartum mental illness. Also an article that was fairly recently published in the Archives of Women's Mental Health Journal. I also have an article that just came out about a month ago in the Journal of Health and Care, which is a commentary on this longer journal article. So feel free to contact me if you have questions. I don't know if we'll have time for questions, but please feel free to contact me to take a look at my website and some of the activities I'm involved in. And this is the postpartum.net is the website for Postpartum Support International that has a wealth of information about pregnancy and postpartum disorders, all different types, contact information, really throughout the world. And then this is the number of our national, fairly new national maternal mental health hotline. So please feel free to share it with patients, to use it, to share it with other providers, and to contact me if you have questions or would like any of these slides. So I like to leave my presentations not only thanking the audience, but with this quote by Margaret Mead: "Never doubt that a small group of thoughtful, committed people can change the world. Indeed, it's the only thing that ever has." So thank you so much for your interest and for attending.
Thank you, Dr. Susan. That was an excellent presentation. I hope the audience have benefited from your views. So any question from the audience side to Dr. Susan?